and Gambia, and the Legion d'Honneur of France. Prof, welcome to CPHI 2022. Over to you.
Thank you very much. I would like to thank you, and I will speak now in French. Mesdames et messieurs, en vos rangs et qualités, tout protocole respecté. Chers organisateurs, c'est avec un plaisir que je réponds positivement à votre invitation. Même si je participe en virtuel, je suis de tout cœur avec vous et je sais que la belle ville de Kigali me manquera. C'est vraiment avec plaisir, je peux le dire, et également avec un grand intérêt que je suis avec vous aujourd'hui, car c'est une question que nous allons aborder, qui est une question qui mérite notre attention. Que constatons-nous aujourd'hui? Les risques encourus par les femmes et les hommes dans le domaine de la santé sont différents, de même que leurs besoins en matière de soins. Certes, les femmes portent les enfants et sont susceptibles de connaître certains problèmes liés à la santé de la reproduction, en plus de leur vulnérabilité biologique accrue en matière d'infections sexuellement transmissibles et de VIH. Des disparités importantes existent entre les hommes et les femmes. Et il faut dire que nous sommes aujourd'hui dans une situation qui mérite vraiment que nous puissions vraiment réfléchir, car les femmes ont un accès aux services maternels et de reproduction à l'intérieur comme à l'extérieur des pays d'Afrique au sud du Sahara précaire. On estime à près de la moitié des femmes, on estime que la moitié des femmes n'ont pas accès aux soins de santé essentiels pendant la grossesse et l'accouchement. En 2017, notre continent comptait environ les 2/3 de tous les décès mondiaux, maternels mondiaux. Mais les forts taux de morbidité et de mortalité des femmes africaines suite à leur grossesse et leur accouchement ne devraient pas nous faire oublier que la femme a d'autres problèmes de santé et que cela ne se limite pas à la seule problématique de la santé reproductive. En effet, les différences biologiques ne suffisent pas, elles seules, à expliquer pourquoi les femmes africaines reçoivent des soins médicaux de moindre qualité. Des facteurs déterminants entrent en jeu, notamment l'environnement physique, économique, les comportements ou croyances des patients et aussi le fonctionnement des systèmes de santé et des prestataires de services. Pourtant, les femmes sont majoritaires comme agents de santé, même si elles sont minoritaires dans les postes de décision et sont garantes de la santé de la famille. D'une manière générale, en Afrique, l'état de santé des femmes est une conséquence logique de la socialisation qui crée et entretient des disparités de genre. L'inégal accès entre les sexes en matière d'accès donc à l'éducation et au travail salarié, à la santé, la faible capacité économique des femmes, les violences sexuelles et sexistes, y compris les mutilations génitales féminines, sont des obstacles majeurs à l'amélioration de la santé des femmes dans la région africaine. L'approche prend en compte des structures et attributs sociaux qui influencent la façon dont les patients, femmes et hommes, et les prestataires de services, hommes et femmes, se perçoivent et perçoivent leurs rôles respectifs. Les anthropologues considèrent qu'il faut souvent tenir compte des proverbes pour mieux comprendre ce qui se passe au niveau donc de la conscience des personnes. C'est ainsi qu'au cours de formation, genre et santé, dispensée par l'Institut de la Banque mondiale, l'utilisation de proverbes africains a permis d'apporter un éclairage sur les croyances et attitudes sous-jacentes qui existent entre les hommes et les femmes dans la société. À titre d'exemple, le proverbe maghrébin « Battez votre femme tous les matins, si vous ne savez pas pourquoi, elle sait pourquoi ». ou encore celui qui nous vient du Sénégal et qui me choque particulièrement, c'est aimer une femme, mais ne lui faites pas confiance. Ces deux exemples suggèrent que les femmes ne sont pas dignes de confiance et sont inférieures et moins précieuses que les hommes et conduisent à des déductions importantes et graves. La combinaison de ces facteurs fait que les femmes sont confrontées à des obstacles spécifiques à leur santé, mais également à leur émancipation. Comment faire pour réduire les inégalités? Je vais juste, pour des questions de temps, développer 5 points avant de conclure. Dans tous les programmes de santé, la perspective genre doit être intégrée dans les politiques, les stratégies, les programmes, les projets, les fonctions administratives, vice-versa, de même que la culture institutionnelle que l'on appelle envers les femmes. Tout développement qui se veut efficace et durable ne peut être obtenu sans la participation effective des femmes, mais également des hommes. Il faut que le travail se fasse ensemble. Le genre ne revendique pas l'égalité mathématique entre hommes et femmes, ce n'est pas seulement le problème, c'est plutôt le respect des droits, de la justice et de l'équité. La clé du développement humain durable, c'est de donner la même chance et les mêmes opportunités aux femmes et aux hommes pour réaliser un mieux-être social, sanitaire, économique, environnemental pour tous et pour toutes. Je voudrais aussi féliciter l'Union africaine qui a mis sur son agenda la masculinité tenant compte donc du genre, et cela vraiment est à mettre en exergue sur notre continent. Et je vous remercie de votre aimable attention.
Thank you very much. Can we keep Prof online for just 1 or 2 questions, please, if we may? Have we still got Prof online? Thank you very much, Professor. And for those who joined us slightly late, we've just had an excellent introduction to our plenary from Professor Awa Kolsek, Honourable Minister to the President of Senegal. Thank you very much. Can we have applause, please? I will kick off with 1 question myself, Prof, and then I will pick 1 question from the audience for time, and Prof is extremely busy and has been very generous with her time with us this morning, so we will only take 1 extra question. So, Prof, last year at the conference, this conference, the inaugural conference last year, we had a side event that explored the role of women in health in Africa through a historical lens. And through that session, we actually learned that the current narrative about the role of women is not actually complete. Women have had much more active leadership roles in health in African history. So my question to you is, how do we reintroduce those positive cultural roles back into today's practice?
I would like to just tell you that we are involved in, I will continue in French. Nous sommes engagés dans une initiative avec la commission du Lancet sur le futur de l'Afrique dans la santé et la résilience économique. Et là, on a justement introduit des éléments d'historique comme la colonisation, comme l'esclavage, comme également le rôle des femmes au plan culturel dans nos pays. Et c'est une nouvelle manière de voir les choses. Nous pensons qu'on ne peut pas considérer que la femme n'a jamais rien fait, notamment en matière de santé. Au contraire, dans l'histoire, on a des femmes leaders au niveau politique, des femmes leaders au niveau économique, des femmes leaders au niveau communautaire, et c'est surtout à ces femmes leaders que je voudrais rendre hommage. Donc, introduire à chaque fois qu'il y a des sessions, des discussions, des recherches, le problème du leadership des femmes, et c'est justement ce que nous avons fait cette année, comme je l'ai dit, au Forum Galien à Dakar, où nous avons fait des sessions spécifiques sur le leadership des femmes. Donc, ça doit être toujours sur l'agenda et ne pas considérer les femmes que demandeuses ou les femmes, les pauvres femmes il y a beaucoup de femmes leaders et grâce à elles, les choses peuvent changer.
Thank you very much, Prof, for that comprehensive response. Do we have one audience question? First hand up. Have we got a roving mic? I don't see any hands immediately up. In that case, I will ask one more question. I'll take the moderator's privilege. Prof, one final question before we let you go. COVID-19 disproportionately affected women's lives and livelihoods. So what do we need to do differently to avoid the experience from the next pandemic?
This is also very important for me because we have learned a lot from COVID-19 with the role of women, particularly women at the front line of the workers, health workers, but women at home, particularly when we had patients, or when we have children who are not going to school. All these are on the shoulders of women. And it is why I think that we have also seen that a lot of response has come from women. We cannot take it aside and consider that women are not doing things. We have concrete examples. We need to disseminate them, and we need also to ensure that in the health system now, and when we are speaking of health, women are at the center of the solution and not at the side. We need to put that center, and this will help us to have better results and to have better health for all.
Wonderful. Thank you very much. Professor, thank you for giving us your time at the conference today. I appreciate that we had to bring you out of your official duties as a minister to join us, and I'd like us to give our thanks to her and continue with the next session. Thank you. So next in this session, we have a panel discussion to be moderated by my colleague and friend, Mrs. Vivian Ihekwazu. Vivian is the Managing Director of Nigeria Health Watch, a health communication and advocacy organization based in Nigeria, advocating for improved health and access to health services. Her work currently focuses on nutrition, maternal, newborn and child health, routine immunization, sexual and reproductive health and rights, and health security. Vivian has over 20 years' experience as a communications professional. Prior to focusing on health, on the health sector, Vivian worked in some of the world's leading communications and research agencies in Europe and Africa in the development and media sector. She was a mentor of the Goldman Sachs 10,000 Women Initiative and other enterprise development programs, providing women entrepreneurs with business and management training. Vivian has an MBA from Gordon Institute of Business Science in Pretoria, a master's in development economics from the University of Sussex, and is a Chatham House African Public Health Leaders Fellow. I'll hand over to Vivian to introduce our panel.
Thank you very much, Dr. Bere, for that welcome. And thank you also for inviting me to co-chair this very important session. I'd like to invite my three panelists onto this session. First of all, I'd like to please invite Dr. Magda Robalo. Keep clapping. Dr. Magda is a public health physician whose career spans over 30 years in the global health ecosystem. She's a former Minister of Health, Guinea-Bissau, and is president and co-founder of the Institute for Global Health and Development. Magda was the World Health Organization Africa Region Director of Communicable Diseases, WHO representative to Namibia and Ghana, and she's a leading voice of gender equality and equity. It's a really pleasure to see you again, Dr. Magda. Welcome. And my second panelist is Ida Hakizinka, Executive Director, AIDS-PAN. Ida is one of Francophone Women Africa Leaders of Global Health 2018 and a proud recipient of the 2022 Kofi Annan Fellowship She's the current executive director of AIDS-Ban, an independent watchdog organization for global health, for the Global Fund to fight AIDS. She has extensive leadership experience supporting the health sector in both Anglophone and Francophone African countries. She has a master's degree in public health and a bachelor's in development economics. Welcome, Idam. And last but not least, Dr. Lwazi Manzi, Head Secretariat, Africa Union Commission on Africa's COVID-19 response. Dr. Lwazi Manzi has 15 years career spans across multiple sectors and has made her into a multidimensional, highly empathetic leader. She's qualified as a medical doctor and in 2018 and spent over 12 years at the front line of emergency medicine. Between 2018 and 2016, she made the transition into film and television, so a very multidimensional career. And in 2021, Dr. Manzi was called to serve as the head of Secretariat for the Africa Union on Africa COVID-19 response, supporting His Excellency, Dr. Cyril Ramaphosa, in his role as Africa Union champion on COVID-19. So, ladies, it's such a pleasure to be moderating this very important session. As Dr. Berra mentioned, last year, for the first conference on public health, there was a session, actually, that focused on women, but it was a side event. So to see this event, to see this session as a plenary really says how important this issue of women in health is. And I think it's, grateful for the conference organizers who actually made this a plenary because it's a very important topic. And, elevating it to this session is very critical. So really, as I said, it's my pleasure to moderate this session. And, for all of us, it's very personal. This is not just about talking about women and health. It's not an abstract issue. As Ebara mentioned, that COVID-19 really had an impact on women, and as mothers, as carers, as health providers. And I think this has made us more conscious of why it's important that we discuss these issues at these events where we convene and talk about women and health. And we realize that without gender equity, there is no universal health coverage. So really, this session, I want us to focus a lot on how we can discuss leadership positions for women, how women's issues can be elevated, and how absolutely we can have women having access to equitable health care wherever they are in the world. So I'll ask first to Dr. Magda. I mean, you've had a very extensive career, and I didn't even give justice when I introduced you. I could talk for 30 minutes on all the wonderful, illustrious things you've done. But one of the roles you play is as the Global Managing Director of Women in Global Health. And that is a platform, I'm sure most of you are aware of it, that has really elevated many of the issues women have and has done a lot of research also in this area. And so one of the things, taken from the Women in Global Health website and from the research done, we know that women hold 70% of jobs in the health workforce. But when a health emergency strikes, we hear the message, step aside. Men are coming through to fix this. So for you, what do you think this impact had on the COVID-19 response, especially as we address and put these issues front and center?
Thank you. Thank you for this question, and it's a pleasure to be part of this conversation about women leadership. Before I try to answer your question, I would like to take this opportunity to pay gratitude, to recognize and to honor, sorry, I never know how to, one great woman leader who left us last year. She was a great leader, passionate about scientist, very committed to neglected tropical diseases. I'm talking about Dr. Mwele Malichela, and I would like a round of applause for her. Now, when COVID-19 started, you said women were told step aside, and actually I had a different experience. In my country, men who were in charge were told step aside, and then I was called in. So at least we could have, but there are very few examples where women were leading the COVID-19 response. And I think the reason is because women within the health sector are very few in leadership positions. They are more in the background, they are within the pipeline, and very few on the front stage. Despite the fact that most healthcare workers are women, particularly those in the front lines, but even when you come at mid-level management, you'll find many women, but very few of them get to leadership positions. Now, the question is why? There are many answers to that question, and we need to recognize that the challenges are within the society that create barriers for women to get into leadership positions. But to solve the problem, we need to work both with men and women. Women have absorbed the cultural norms from society, and sometimes, many times, they don't even realize that they are sometimes the first obstacle from them to move to leadership positions. When you do a survey and you have most women telling you they feel normal to be beaten by their husband, then you know there is a problem that is inside. We have been educated to believe that we don't take the front seat, and until we learn to unlearn that, it will be difficult. Like Professor Awakolsek said, it's not a competition. We need to be allies. We need support from men. Otherwise, it will not be possible. I wouldn't be able to do the few things I've done if a man in my life, my husband, wasn't supportive. So we need to go together on this. I will stop here.
Thank you very much for that. I mean, there's so much you said in terms of women ourselves sometimes being the barriers to pushing forward, but also there's structural and societal reasons why women do not often push themselves forwards or are put in those leadership positions. But also there are regulations and laws in some countries that enable that. So it's wonderful to hear that, in fact, in Guinea-Bissau it was a bit different, that women were actually in front. I mean, going to you, Ida, I mean, Rwanda, I mean, we all had a wonderful welcome since we all arrived, is one of the few countries globally that has achieved gender equality, especially in ministerial positions, with at least 61% of the ministerial positions being held by women. And what does this mean? It means that we see women in leadership positions. So they are role models that women can also see to aspire and know that actually I, as a woman, can become a leader because I'm in a country where you see women in those leadership positions. And that is really important, especially how we see ourselves. For you, how has this shaped yourself and how your career has grown and how you have taken up leadership positions when you see women as those role models?
Thank you for the organizer to have me here. But I will start by saying I'm a firstborn of a family of 6 girls. And I've grown up seeing my parent, my mom, being called name of having so many girls. So from that, I grown up and seeing my aunties not accessing education, not being pushed for earlier marriage. And then come our leadership. His Excellency Paul Kagame and our First Lady. And there was a push for us as women, young girls, to go further and to go beyond our barriers. And we had that opportunity of having ourselves having an enabling environment to be able to grow and access even where we said sky is not the limit. And we are like able to go beyond those barriers because they were able to break the barrier and our traditional architectures. And at the end, where I'm finding myself, I'm like, when I'm going in meetings and listening to other women, I'm feeling I'm really speaking for a privileged position because I've never faced same challenge like other women. Since my beginning from my earlier universities years, joining the workforce, I found out I was just like, the performance matters more than being a woman or younger. So that have been able to let us, and having me here, and our enabling leadership policies, and our elders, our predecessors like Dr. Magda, and have shown us a way where to go. Thank you.
I think you're right. I mean, I mentioned, we see women as role models, but I think some of it starts before that, in coming from homes where, you have a father, we have a husband who actually also supports you in taking up those leadership positions. And that also, I think, is important in how young girls see themselves, project themselves. So it's wonderful to hear that you're, one of the first to have taken up those, kind of leadership positions. And this is very important in how we go forward, so the future generations actually know that those leadership positions are open to them, and also men are the champions. I know sometimes when we have these kind of conferences, they think, oh, what about the boys, and what about the girl, or what about the men? But we know that because these issues are often discussed with women front and center, that these types of specific, panels are important, and these discussions specifically are also important. My next question is to you, Dr. Manzi. I think when I looked at your bio, it was wonderful to see you started, clinically, you trained as a medical doctor, but then you now are part of the Africa Union Secretariat. So you've done a lot of work in terms of messaging and how we see women, and your role from clinical to working in the media has seen you understand how communications is very important. So, we've spoken a lot about how women see themselves, but the media also plays a very important role in shaping how we project women forwards. We can't ignore that. In as much as we're talking about health now, the media also plays a role in that. So, women's issues are highlighted in the media, but when it comes to who is in charge, the directors, the producers of shows, they're often men. And when we sometimes ask for experts to come and discuss issues, sometimes relevant to women, they're often men. And maybe it's that women are not put forward in those positions, or the directors don't often think of women as being able to speak to those issues. So, how do you think we can increase the momentum of seeing women as the producers of shows, or putting women in those positions where we can shape the narrative? And this all leads to how women's issues are elevated in the media.
Thank you very much, and please feel free to stop me, because now you've got me on a topic that I'm very passionate about, and I can go on and on. So, absolutely, I went from, at the time when I was a student, from a white male-dominated career, or rather industry, which was the medical industry, to an even more white male-dominated industry, which is the film and television and entertainment industry. And certainly as somebody who went in as a producer, and when I went in, I actually was very pointed about my ambition to be a producer, and indeed my ambition to be an executive producer. Now, many people don't know how it works. What's a producer, what's an executive producer, and all of that. But the executive producer is the one really that raises the money. So I wanted to be rich, and I wanted to be the one that raises the money so I can take my 10%, and that's what I wanted. And the first thing I was told is, no, you can't do that. First you must be a runner, and then you must climb your way up. And I said, no, I'm not going to do that. I'm going to be an executive producer. producer. And I did, and I did that for 7 years, and I think quite successfully. Now, when it comes to representation of women, I just want to reflect on a point that was made by the Honorable Minister, that representation is actually a developmental issue. And I thought that that was really a very, very poignant point that she made there. And the representation of women, and particularly women of color, is equally as important in front of the camera as well as behind the camera. If you do not have representation behind the camera, you will actually, and you will all have seen this in various pictures that you've watched, you will see the discrimination of women even in front of the camera, even when that story purports to actually be telling a story of a woman of color. And so, you know, when we actually look at the film and television industry and we look at the way that it's evolved, you will remember that when we were watching movies in the 70s, the 80s, and all we ever watched was white males. We watched Tom Cruise, we're still watching Tom Cruise running across the plains, saving the world, you know. But because of women like Ava DuVernay, Shonda Rhimes, Masai Martin, who was a 13-year-old executive producer when she started, Oprah Winfrey, Bongiwe Selane, closer to home, and Viola Davis, who produced The Woman King, you are actually starting to see a shift in the way even these stories are being told and in the perspective that you are actually getting from these stories. When I started out as a producer, one of the main things I was aiming for was to tell Black stories, and I wanted them to be commercial. I didn't want you know, another apartheid story or another sob story. I wanted commercial sensibilities to the story so that Black stories actually sell. And it's important for Black stories to sell and to be pushed out into the international market, because that's the only way people are going to actually connect with Black stories. You know, people always think that you have to have an art house approach. No, if you want impact, you actually must ensure that you sell. So you can already see that just me being Black and being female, already there is a kind of a rebellion and a push, you know, that is coming from me, whereas, you know, if it was a white male, they would say, oh, you know, tell an art house story, you know, that is touching and all of that, that may be seen by like a handful of people. No, we want our stories to go out there and to be consumed in the same way that Americans have been able to also push their content out to a point where it is being consumed by ourselves, and to a point where we even have American sensibilities in the way that we live our lives, because film and television is extremely powerful and very, very influential. Now, I was told that in order for me to be able to do that, I must have a white lead. I must have a white lead, and and it must be in English, because that's the only way you're going to actually be able to sell your story. And so actually that is what I did, because I wanted to be able to push out the stories. But because of these women, we are now seeing the Black Panthers, the Woman King, those kinds of films that are really, really being pushed out there. Now, I want to say that in reflecting again on Prof's point, and I'm going to end here with your question, that we still have more stories to tell about people like myself, you know, who have moved between the science and the medicine and film and television, and women who have pioneered medicine, but the credit has been taken by men. And I'm talking about women who took leadership and have really contributed to the developmental agenda. Women like Marie Curie, who invented the X-ray. Women like Rosalind Franklin, who discovered DNA. Women like Lady Mary Wortley, who at the same time that Jenner was starting to inoculate smallpox, she was also inoculating against smallpox at a time when it was actually forbidden. Women like Hedy Lamarr, who's like me, she was better known actually as a Hollywood actress. You've probably seen her in old movies. But in fact, she was the one who invented what was called at the time frequency hopping, but now which forms the basis of Wi-Fi, GPS, and Bluetooth. Those kinds of stories can really only effectively be advanced by women producers like myself. And so we really would like to see that kind of content being pushed out there. Thank you.
Much, Dr. Lwazi, and for your very detailed response. I think you spoke a lot about how the industry has actually seen movies like Black Panther and Women King come out now, which is very important. And I intentionally pivoted to the media because it speaks a lot about how we see ourselves and how we're projected. So over to you, Dr. Magda. There was something that Professor Sinead said yesterday, which is quite profound when we talk about representation. She said, if you're denied a place at the table, bring your own chair. Very, very profound. And that's very important in how we take up those leadership positions where we're not often invited. So we know that that women are poorly represented in leadership positions. I mean, you mentioned that, in Guinea-Bissau was a bit different in terms of the COVID response. And this, in other countries, has placed limitations on their ability to initiate policies that meet their needs. How do we hasten progress to ensure that women are sitting at that table where decisions are made about their health? Or are we saying we should be pulling a chair for ourselves?
I think we need to understand that if there is a table where a conversation is happening and you are not invited, you don't have a chair, there are several things you can do. And one of them is to consider creating your own conversation around your own table with your own chairs and bring the people who are interested on the things you want to say that probably people around the other table are not interested in. I think this is what is happening. We are willing and struggling to sit on a table where we are not invited, we are not wanted, and we think that's the only option. It is not the only option. We can create our own narratives. We can create our own conversations. The conversation here is about how do we have a power shared between men and women, between the global north and the global south, between white and black, etc. But I think there are opportunities for us to move the center of gravity somewhere else and then create your space in order for you to contribute to what needs to be done. It's easier said than done. But I think the world is not just one color. There are different shades of gray, and we need to find space or create the space for us to fit in. I think this is the movement that is happening right now around the world. We are moving from bipolar to multipolar to unipolar worlds. It's exactly because we have groups of countries that have decided that their model of development is going to be different. They have decided to do things differently and create gravitas around them. And I think that's part of the things we need to be doing. Number two, I think the power struggle between men and women is one that should be seen in a perspective of multidimensional or what we call intersectional debates. I think education in the long run is what's going to make a difference within societies and across the world. But we know that will take time. As long as we still have young girls taken to marriage at a very young age, it is going to be difficult, but education will be the solution to those problems. Sensitization, networks of women. There are many women leaders out there in the communities. We don't see them on television, we don't hear them, but they are out there struggling to put their children in schools because they appreciate the fact that having not been in schools has been a handicap for them. Women are being sidelined in many countries except Rwanda in terms of the political space to become parliamentarians, politicians, ministers, and then have the opportunity to use power to change society. And we need to make sure that also within political parties, we do participate, we do work in order to change the narrative. Not every country will have that leader up there who will be willing to change society with transformative actions. We need popular movements from bottom up in order to transform a society the way we want it to go. The last thing I would like to say is we need to make sure our boys are educated differently. Otherwise, they will be perpetuating the same repressive, patriarchal attitudes that their parents have passed on to them. So, thank you.
Thank you so much for that, Dr. Magda. I mean, there's so much to unpack in terms of what you've said, in terms of women creating our own discussions, in terms of legislation, or in terms of women's representation in ministerial positions. And you mentioned, of course, the importance of how we bring up our boys. I mean, I have 2 boys, so for me it's extremely personal. But I think the point you made about ministerial positions, I mean, in Nigeria, we're absolutely struggling with this. In the Senate and in the House of Reps, women are heavily underrepresented. And we had a gender bill that was recently struck down. And who struck it down? The people who are there, we know, men. And so that makes that journey a lot harder, but we have to push on. So thank you for that. My question now to you, never give up, absolutely. My question is to you, Ida. Yesterday, on the day before yesterday, I was at the side session on the Kofi Annan Leadership Fellowship, and you are a proud recipient of the 2022 Kofi Annan Fellowship in Public Health. Clap for her, everyone. And some mention was made of, as part of that fellowship, how much is discussed about the role of women, and how much leadership training did you receive, yourself? So with this new confidence you have and the tools you've gained, in what way do you think this has positioned you to be a better leader? And what would you now say to young girls who are aspiring to leadership positions?
Yes. So thank you for the question. I would like to speak in French because some of my colleagues, fellows, have requested me to speak in French. So, je voudrais dire que je suis vraiment reconnaissante pour l'Africa CDC, de m'avoir sélectionnée et de faire partie de 20 sélectionnés qui font partie de la cohorte numéro 2. Ce que je voudrais dire, je me dis que quand on parle de fellowship, ce n'est pas vraiment du fellowship. It's Kofi Annan movement. It's not a fellowship. Oh, so sorry. I need to go back to French. OK. Donc, je voudrais dire que c'est le fellowship, ce qui nous a permis, ça nous aide à nous catalyser, à renforcer ce que je peux dire, nos possibilités, et apprendre fait que dans l'espace que nous occupons, nous pouvons faire mieux et faire plus pour l'Afrique. Ce n'est pas seulement un cours à l'ordinaire, comme on a fait ou bien les autres ont fait, là où on va, où un professeur vous explique, mais c'est mieux où on est même appelé à visiter plusieurs pays et à faire partie de l'expérience. On a eu à visiter par exemple l'île de Gorée, et on a aussi visité le musée de Renaissance, où vous vous rendez compte que on est des privilégiés aussi, je peux le dire, et qu'il y a eu beaucoup de sacrifices avant nous pour qu'on soit là où on est. Et de ces faits, on apprend à faire plus et à comment gérer non seulement la famille, mais les collègues, et même aller et qu'est-ce qu'on peut faire et s'interroger toujours plus de ce qu'on peut faire pour l'Afrique. Et l'autre chose que je voudrais dire à tout le monde ici présent, s'il vous plaît, rejoignez le Kofi Annan Movement, notre fellowship. Et s'il vous plaît, l'autre chose que je veux souligner, c'est là où on dit que si vous voulez être un bon leader, vous devez vraiment prendre soin de vos proches, prendre soin et être à l'écoute des besoins de votre population. Et là où on parle des jeunes filles, des jeunes femmes, des adolescentes, parce qu'on fait face à ces problèmes des adolescentes qui ont des grossesses précoces. Donc, à être à l'écoute, vous pouvez adresser mieux leurs besoins. Et quand on parle de leurs besoins, ce n'est pas seulement leurs besoins d'éducation, c'est leurs besoins à partir de la maison et en dehors de la maison, comment on peut les réintégrer dans les systèmes. Parce que de notre tradition, dès que vous aviez un bébé, vous devenez juste... donc, on vous mettait de côté. Et l'autre chose que j'ai dit à tout le monde, si vous voulez être vraiment un bon leader, restez toujours à l'écoute, comme l'est notre président.
D'accord, merci beaucoup.
Merci.
And I stand corrected. It's a movement, not a fellowship. And yes, you are very right. To be a good leader, you absolutely have to listen to women and girls. You have to listen to their needs. You have to listen to women because we play multiple roles as mothers, as wives, as friends, as sisters, etc. So absolutely, you're very right. A good leader has to be able to listen to the needs of girls, very young girls, and women especially. So thank you very much for that, Ida. My next question is to you, Dr. Luazi. I'm sure, I think we're running out of time, Aberi. I think I can see you walking towards me. I'm not sure if we have time for one question, but I'll ask Dr. Luazi one question, and then I'll take one question from the audience. So my question to you is, in your current role as a head of Secretariat, Africa Union COVID-19 Commission, when we had the vaccine rollout, the spread of misinformation played a role in how women accepted the vaccine. And a lot of that has to do sometimes with the messaging. How well do you think we have done in understanding how women consume media, how women receive information from the most basic thing? Like, example, in Nigeria, many women don't have access to a smartphone. So how do you think we have listened or understood that in educating them about the importance of, for example, taking up the vaccine?
Thanks very much for the question. I'm going to give you an example from South Africa, which is actually paradoxical to what you've just said, but then I'll throw it out to the entire AU. So we approached, so after the film and television industry, I was brought into the Ministry of Health as the spokesperson because of my skills of having film and television and of course medicine. And then I was from there moved into supporting President Ramaphosa in his role as the champion on COVID-19. Now, while I was a spokesperson and we were rolling out the vaccines, we approached the Human Science Research Council, HSRC, and we said, look, we want to see what it looks like with the vaccination, men and women. And we were very surprised to find that actually there was a huge disparity between men and women, and in fact, it was the women who were in the lead. So we had I can't remember the exact numbers, but it was something like 70% of the vaccinations were women and 30% were men. So we said, oh, well, then in that case, we need to change the way we deal with the messaging. And we said, we're going to get the women to talk to the men to get them to go vaccinate. So we worked on a campaign and all of that, and then we said, ladies, tell your husbands, tell your brothers, tell your sons, and all of that, to go get vaccinated, and if they don't, you're not going to give them, or you're not going to do this, or you're not going to do that. And in fact, we actually saw the gap closing. So what we did, actually, in principle, is that we shifted the role of women, you know. Since they were the pioneers, we then made them the leaders. And exactly as you say, if you see a mother, a sister, a nurse who is a woman as community leaders, you then actually create circles of influence, essentially. So, so the center of that circle of influence is the lady, and they are the ones then in their home, in their community, in their constituency, etc., then actually expand the circle of communication until you actually get a message to land, and you actually see real change. So it really depends on how you actually view you know, a person, you know, in their, as a leader in the role that they play in the community. Now, throwing it out broader to the AU, indeed we did find that there was an issue where we saw that there was the opposite now, you know, where women were not actually able to access. And it was a matter of actually appreciating the reality for that woman. There were lockdown realities where we found that women became like the primary caretakers, not only of their children, but of the elderly, of men, of animals, of the garden, of the house, of everything. And it was just difficult for them to actually just get out of the house in the first place. So, and we can go on, and I know we're running out of time, but essentially the fundamental message was, actually we've got to take the vaccinations to the women. You know, we can't expect them to, like you say, have a cell phone and know, oh, okay, you can locate a clinic there and then you can walk there or whatever. Not gonna happen. Identify where the communities are, identify, in fact, one beautiful example was, again, from back south, a 109-year-old woman who took the vaccination, but we had to actually vaccinate her at home. And then we put her on the front page of the newspaper for being vaccinated. She was all over the news. And the message was, you know, if she cares so much about her own health at 109, you know, then what excuse do you have, you know? And it was such a beautiful message, but it was also a message of hope for people to say that we are a caring government. We are coming out to you. We will be there. Tell us where you are, and we will go there. So the message really switched back to us. But again, if you have women who are in the positions, they are able to actually bring home the message to the lawmakers and the ministers of finance, who are usually men, and all of that, to say, well, we need money for these things, you know? And in that way, we're able to then improve the numbers of women who were able to be vaccinated. And we're going to have to carry on doing that kind of thing and scaling that kind of thing, where we really bring commodities, really, to women, particularly sexual reproductive commodities, to women where they are in their households. Thank you.
Thank you very much, Dr. Lwazi. Unfortunately, we've actually run out of time, so I'd hoped to have taken one question from the audience, but unfortunately, I've been told by Dr. Berry, I can't. But you are absolutely free to come and speak to any of the panelists afterwards and ask them the question you would have wanted. So this doesn't negate the fact that we don't have time right now. So I'll just summarize or just finalize by saying it's been such a pleasure to moderate this session. It's been amazing speaking to all three of you. And I think the very important lessons that they've shared with us today, Dr. Magda, we stand on your shoulders. We look at leaders like you, and we know that leadership is possible through the work you have done and seeing everything that you have done. And hearing what you've mentioned today about attaining leadership positions, about women creating our own discussions and not always waiting to be invited. To you, Ida, thank you very much in talking about your role as a leader and how it's so important as a leader to listen, male or female. To be a good leader, we have to listen to the needs of the people who we are leading. Dr. Lwazi, I have so many more questions to ask you. I was fascinated about your pivot from clinical to media and then now back into clinical, and you're absolutely right. The media plays a critical role in how women are seen and how we are represented and how that narrative is shaped about our ability to even be leaders. So thank you ever so much for this very, very interesting panel session. I just want to say, please give a round of applause to all our panelists. It's been a very enlightening panel session. I think we're now going to have a short video from the Executive Director of UNAIDS, Miss Winnie Yaima, I'm sure all of you know her, talking about women leaders. She's absolutely one we look up to, especially in terms of ensuring that women have equitable rights and access to HIV treatment. So cue video. Thank you very much.
Dr. Okereke, my sister and co-lead of the Women in Health track, Excellencies, ladies and gentlemen, I'm pleased to join you for the second International Conference on Public Health in Africa and to share my thoughts on gender equity in health. Let me start by addressing women's gendered needs in health. Women have unique health needs based on their sexuality, their gender roles, and the risks that come with those. Here in Africa, it is the intersecting axes of poverty, patriarchy, and violence that come together to crush women and girls, undermining their health and limiting their access to health care. And this has terrible consequences. Globally, more than 800 women and adolescent girls die every day from preventable health issues related to pregnancy and childbirth. Women in Africa account for more than half of the deaths of women worldwide due to communicable diseases. In our region here, adolescent girls and young women are 3 times more likely to be infected with HIV than boys and men of the same age. So challenging patriarchy and gender-based violence, overcoming poverty, and providing women's sexual health care are priorities that must be pursued together, not one after the other, or one traded off with another. Turning to women as healthcare providers, women are the main providers of all aspects of primary health care: nutrition, sanitation, water, healthcare, in their households and in their communities. Women are the daily carers of children, the physically challenged, the elderly, and even of their own partners. This cuts across economic class and geography, rich or poor, rural or urban, global south or global north. Providing health care at the family and at community levels persists as a woman's gender role. UN Women data shows us that women and girls do over 70% of the total amount of unpaid care work, that globally women and girls spend 3 times as much time on this work as do men and boys. Women work harder and longer, and by putting others' health needs first, their own health is often undermined. Turning to community health work, women are 70% of all community health workers globally. And it's not a coincidence that such work is unpaid or underpaid. It's simply a gender injustice. Take Juliana, a community health worker in the sprawling informal settlement of Eastleigh, Nairobi. Juliana, in her early 20s, is HIV positive. She's called a mentor mother in the HIV world, and she links women in her community with life-saving HIV services. For this important work, she gets paid just $20 a month. An injustice. Feminists have proposed ways to measure and include unpaid care work in the value of the economy so that it can be fairly rewarded. A consensus is now emerging to go beyond GDP in measuring socio-economic progress. We must ensure that any new measure now includes unpaid care work. I now want to turn to women in the formal healthcare sector. Did you know that 24 million of the 28.5 million nurses and midwives globally are women? That is 85%. Or did you know that in Africa, women are nearly 60% of the paid healthcare workforce, but less than 30% of doctors are women? So while across the world, women are the majority of paid health workers, they are concentrated in the lower levels. Public health decision-making is dominated by men, with women holding just 20% of the senior leadership roles. When it comes to policymaking, women are only 25% of parliamentarians globally. So women are underrepresented in policymaking, in planning and budgeting for healthcare. Is it then surprising that the health needs of women and girls are not fully met anywhere in the world? We must move faster towards gender parity in senior positions in public health, in parliaments, and in local governments. This is not difficult. It's a question of political will. I salute the African Union, which has recognized the importance of women's leadership in health. Since its inception, the commissioners responsible for health have all been women. Finally, a call for greater support to women health entrepreneurs. I'm excited to see more and more women, a lot of them young women, leading businesses and social enterprises to solve health problems. I've seen figures that show that women-led startups deliver 35% better returns and create 6 times more jobs. Yet, I've also seen that less than 2% of venture capital investment goes to women-led startups. This must change. Increasing women innovators' access to capital will improve women's health, grow economies, and bring benefits to all of society. In conclusion, let us invest more in women's leadership to achieve gender equity in health in Africa. Thank you.
Thank you very much. Thank you. We now deviate from traditional conference proceedings and we are having a debate. We thought we might shake you up a little in case your coffee hasn't kicked in. So, the AU Agenda 2063 has Aspiration 6, which declares a desire for an Africa whose development is people-driven, relying on the potential of African people, especially its women and youth. The goal is to strengthen the role of African women through ensuring gender equity and parity in all spheres of life, political, economic, social, eliminating all forms of discrimination and violence against women and girls. So today, we ask our speakers, our debaters, to reflect on these aspirations and to debate the motion, Gender Equity in Health Leadership in Africa. Have we made progress or gone backwards? So, we have 2 teams, and I will introduce the speakers and ask them to come and take their seats on the stage here. Your first speaker in support of the motion is Dr. Esmahan Bebeka, a community medicine physician based in the Federal Ministry of Health of Sudan. Dr. Esmaha has over 20 years' experience in hospital management, primary health care focusing on maternal child health and nutrition, and she has contributed to the development of several key national strategic plans in Sudan for maternal and child health and nutrition, and was part of the task force that developed Sudan's National Health Strategy 2020 to 2024. She has extensive experience as a trainer of health professionals on all levels and participated in the development of technical guidance for the continuity of maternal and child health services during the COVID-19 pandemic in Sudan. Welcome. Our second speaker, also in support of the motion, is Dr. Nora Obudo. Dr. Nora is a medical doctor with extensive experience in leadership, management, and public health. She leads Women Lift Health in East Africa with a mission to expand the power and influence of talented women in global health and leadership. Her career spans over 15 years, during which she designed, managed, and led teams in various public health programs, including HIV, sexual and reproductive health and rights, and empowerment. She's a graduate of the Nairobi University with a bachelor's degree in medicine and surgery, a master's degree in public health from the Hebrew University of Jerusalem, and an alumnus of the Afia Bora Consortium, where she attained the certificate in global health leadership through a partnership between the Universities of Nairobi and Washington. Welcome, Dr. Nora. Please take a seat. Now, our first speaker opposing the motion is Ms. Faith Nekabari Imfi. Faith is an outstanding international public health professional and currently the program coordinator for public health workforce development at Africa CDC. Ms. Faith is a member of the Global Burden of Disease Advisory Council in the USA, and she has worked in the United Nations Population Fund East and Southern Africa Regional Office and the Center for Statistical Analysis and Research, both in South Africa. Faith holds graduate degrees in demography, public health, and population studies, and at BA and MSc level from the University of Witwatersrand, South Africa, and a professional certificate in leadership and management from University of Washington. Welcome, Faith. And our final debater, also opposing the motion, is Ms. Stella Bosire. Stella is the inaugural executive director of the Africa Center for Gender and Health Systems, a startup that looks at strengthening health systems to be gender responsive. She performs gender analyses from grassroots to the highest political levels and across all sectors. She previously worked as the co-executive director of East African Sexual Health and Reproductive Rights Initiative and the chief executive officer of Kenya Medical Association, vice chair of HIV/AIDS Tribunal in Kenya, and is currently a board member of Amnesty International. Dr. Bosire is a medical graduate of the University of Nairobi with a master's in business studies from Strathmore University and a second master's in global health policy from the London School of Hygiene and Tropical Medicine. She's actually currently studying law at the University of Nairobi. Welcome. Those are your debaters. So, unfortunately, Professor Slew, who was supposed to be a moderator for the debate, was unable to join us for one of those reasons that women are disproportionately affected. Family care responsibilities. So I will be your moderator, and these are the rules for the debate. The first speakers on each side get 2 minutes, and I have a buzzer, and I will use it. The second speaker gets 1 minute, and then I will invite the first speaker to have 1 extra minute to rebut any of the arguments that the opposition has made, and after which we will go to the audience for a vote. So audience, please, I ask you to bring out your smartphones, and we will shortly display the web link or QR code so you can go to the Menti site so that you can vote. But please do not cast your vote until we've concluded the debate. So if the tech can just display the link to, yes, that's your QR code, that's the link, so get ready to vote in the next few minutes. So I will invite the first speaker in support of the motion to open the conversation, open the debate.
Hope I still have my few seconds. So in any debate, we always begin with definitions. What is progress? And I think that is what we're going to base on so that we can have a solid place to have this argument. And just looking at the definition, it's the path of learning and action towards the direction of reducing threats and missed opportunities. And of course, also working on the capabilities. So we have to have capabilities, and we have to look at the threats and the opportunities that we have. But when we look at gender equity, what is gender equity? It is essentially based on the principles of fairness and justice. So when we're talking about fairness, it is without prejudice and, again, favoritism. And when we look at what impartiality means, it's ensuring that we have those opportunities for women, men, transgender, and the non-binaries. So we're looking at this situation in context. And as we look at leadership in Africa, have we made progress in that area? And I want to say, of course, yes, because there's been learning and action towards it. It began with the Beijing conference. And now we have moved as to leaving no one behind and ensuring that we are looking at women in terms of what the community and expectations should be enabling for them. As well, we've also looked at different actions that have come up in process. We've seen UNESCO working on mentorship programs to increase employability. We've looked at programs as well in Kenya, Tanzania, and Uganda looking at increasing their empowerment for women. But we've seen a lot of progress. For an example is here in this conference, women's discussions used to be a side discussion. Then now it's a plenary. And we are moving now to a conference where it's about the women's agenda. That is progress. When we see women storytelling, we hear stories of Professor Agnes Binagwaho told in a story. That is progress. Thank you.
Thank you very much. Thank you. So if I could ask our first speaker opposing the motion to start.
Thank you. Thank you very much, and good morning, everyone. I overhear my co-debater saying that just because there have been programs that have been geared towards improving women's participation in leadership, that is project. I dare to say that is not project. We've heard from the previous panelists about how, and very recently, the world has increased its population to about 8 billion, and women continue to provide essential health care to 50%, more than half of that population, about 50 billion people. Yet they don't have the requisite seat at the table to make decisions that borders on the health. I'd use COVID as an example. In the national COVID-19 task forces in our different countries in Africa, women were the majority of the frontline health workers, yet they didn't have a seat at the table to make decisions around how COVID was responded to. I dare to say that is not progress. Over the years, we celebrate International Women's Day under themes, with support from our allies, the men, under themes such as Each for Equal, Break the Bias. Yet, women are still very underrepresented when it comes to health leadership. You heard the UN's director, Madam Winnie Byanyima, when she talked about 25% of women being in leadership positions, even though 70% of the health workforce are women. So I dare to say that is not progress. In the words of Rumel, she said, Africa has dealt with women in leadership as the known and the unknown. The known because we all know the numbers, we all know the factors that continue to deter women from taking up these positions. The unknown because we pretend not to know, and we decide to come up with issues such as unsolvable cultural norms, and then use that as a way of protecting against the loss of centrality. So to you, my dear opponent, I dare to say no progress, little or no progress has been made. Thank you.
Wow. Excellent. My timer hasn't even gone off. There we go. Thank you. Now, I invite the second speaker for the motion. You have 1 minute.
Thank you very much for this chance. I think the restrictive gender norm affected everybody, and it is transformed in the health risk and a barrier. From my experience of 20 years, that I found that this notion is slowly and steady reducted and in the way of to be disappear. So in the Federal Ministry of Health in Sudan, we made a progress that we have 70% of the health workers are women, and about 5 general directors are women also. And I think it make like a little bit change in the how we are look different and using the different lens for the issues. Thank you.
Thank you. And our final speaker opposing the motion.
Let me first check my microphone. 1, so I'll be very factual like a lawyer. Existing barriers. Women's work are heavily restricted, demoralizing parental policies, participation of women and girls in STEM is limited. 2, norms within the workplace that are non-progressive, lack of visible accountable leadership, existence of conscious and unconscious bias, minimum male champions of gender inclusivity, lack of gender transformative recruitment policies. 3, lack of enablers to motivate women in leadership. 1, no support for formal and informal networks for women in healthcare. 2, we do not track public metrics that measure gender inclusion. 3, minimum investment in peer development of women. Hence, the existence of Africa Center for Gender and Health Systems. Thank you.
Fantastic. That is how you use your time. We still have 14 seconds on the clock. Wonderful. So I invite the first speakers to respond. And like I said, you will have 1 minute. First speakers from each side only, 1 minute.
End of the day, we have policies. WHO has embodied the work that we're doing around women's leadership. We have partners working, including Women Lift Health and Women in Global Health, advocating for women's leadership. And we are providing leadership programs, looking at institutions to enable environments for women. And we're also having the societal conversations around this. This is progress. So we have to start from data, and from data we have action, and that is what defines progress. It's movement towards learning and action, and managing the missed opportunities and the threats while enabling capacity.
Thank you. Right, and our final 1 minute.
Thank you, my opponent. I sort of thought you were going to say that. Why there have been a lot of programs geared towards improving or advancing gender equity in leadership and health, are there existing monitoring and evaluation frameworks that are traceable to this progress? My bet is there are none. So I dare to say the fact that we put out a lot of programs and assume that these are yielding ripple effects in advancing gender equity, I dare to call that the illusion of inclusion. Thank you.
Wow. That's wonderful. Thank you. Thank you to both our teams and to the exciting, very, very concentrated summary of the issues relevant to this topic. So I'd now like you to, please, if you haven't gone, go on Menteam and vote. And tech team, can we show the results screen, please? Please cast your vote for or against the motion. I hope it works. Aha. Keep going. There are a lot more than 200 people in this room. Okay. Right. Can we show the results screen again? We've changed slide. Right, we're conscious of time, so I'm going to call it, and it looks like the ayes have it. So the debating team in support of the motion, congratulations, you seem to have won the vote. But I can say that our opposition did an excellent job. And the key thing is that they've raised the issues both in terms of progress and opportunities that still need to be leveraged in this space. So I'd like to thank our debaters and ask them to return to the panel. Thank you very much. We started a few minutes late, so I'm going to crave your indulgence to stay with us for our last two quick fire presentations, and these are really important. Our next two and final speakers in the plenary represent intersectionality in gender equity. We will take, hopefully if we have time, one question to both ask the next speakers. So our first speaker coming on stage now is Ms. Ronke Oyebanji. Ms. Ronke is a public health professional currently working for the Coalition for Epidemic Preparedness and Innovation, CEPI, as a policy and partners manager. She has a few years' experience in working in public health leadership, supporting public health leadership in the public and private sectors. She was a technical assistant to the Director General of Nigeria Center for Disease Control, where she supported the development of key policies, strategies, and projects, including NCDC's 5-year strategic plan. Ronke is a senior fellow of Aspen Institute and a doctoral candidate at the London School of Hygiene and Tropical Medicine. Ronke will speak to us about the future of gender equity in Africa from the perspective of a future leader. And she has a really short time, and we will take questions after a subsequent one.
Thank you so much, Dr. Ebere. I'm really happy to be here, and I've learned so much from the sessions in the last few days, but especially from having a INT'L, a panel made of only women, and it's the first time I've ever seen it, so thank you for pulling this together. Give young people a chance. Give them responsibility and leadership. These were the words of Dr. John Nkangasong a few months ago when he accepted the Vachel Prize for Global Health. There are events that serve as catalysts in our lives. For Dr. Nkangasong, for me, and I'm certain that for most people in this room, those events came because someone gave us a chance at a young age. In 2016, I completed my bachelor's degree in public health at a university in Nigeria. In the years before graduation, I had sought out internship opportunities, and so I already knew that it was very hard to find a job in public health. I mean, even older and more experienced public health graduates struggled to find jobs. To put it into some context, at the time, Nigeria's unemployment rate was about 14%. You can guess that, yes, there were more unemployed women than men. However, and by what I call a mix of risk and opportunity, I got a chance to work in a high-pressure role as technical assistant at the Nigeria Center for Disease Control. I call it risk because my manager did not know me beyond a few interview sessions. I had just graduated out of university, and so I had very limited work experience. But opportunity, because it was one of the first catalytic events in my life. Over the last 6 years, I have benefited immensely from several risk and opportunity mix. From my career path to getting to speak at conferences like this. But it's not just about me. I'm one of several young people that have gotten opportunities and are supported through this. But there are still many of us, especially young women, who are being asked to wait their turn. Allow young people to lead and trust us to do this. Provide an environment so we can thrive. We have proven that we can do this, and I mean, if you're looking for evidence, you should meet my former colleagues from the Nigeria Center for Disease Control. Supported by older and more experienced professionals who are deliberate about mentoring the next generation, many of them have gone on to lead the establishment of emergency operations centers, to establish a biomedical engineering hub that serves the entire country. Many of them have gotten fully funded master's and PhD opportunities. And this might really sound flippant to some people, but for some of us, the job at NCDC was the first time that we got to leave Nigeria. And so it is important that we're deliberate about supporting the next generation. Give young people a chance. Give us opportunities. Support us through it and watch us thrive. I have learned very quickly to live by the quote, identify your problems, but give your power and your energy to solutions. I have also learned that opportunity is not where it ends. Sometimes what truly matters is what you take that opportunity and what you do with it. For many young people, working in our region is hard. The poor salaries, the limited opportunities for far too many people, and sometimes an incredible workload. But young people have an advantage, and that is our energy. For some people, it could be thankless work like updating a website. And you know, nobody really thanks you for a website until something goes wrong and they scream at you. In the same vein, I have seen young people feel entitled about opportunities, which they did not just end up losing, but they ruined a chance for several people who could have come after them. Just like we see with women in politics, there are people waiting for women and young people to make just one misstep so that they can prove that young women cannot lead. And so, in everything that you do, please think about how you can give it your best, because it's not just about you, it's for all of us. In his Vachel Prize, Dr. Nkangasong spoke extensively about how he got the opportunity to go to Belgium to study for a master's, a PhD, and eventually lead a lab at just 34 years of age. Our best leaders speak about how they've benefited from mentorship. And so no matter how far you climb, please look back to figure out how you can pull up others along the way. In your jobs, think about career paths for young people.
Share opportunities with us and keep the door open so that we can come after you and keep it open for more people. Have more programs like the Kofi Annan Leadership Program, which I really admire, but some that are deliberately targeted at developing the next women leaders in Africa. And paying it forward is not just for senior or more experienced colleagues. It's never too soon for those of us who have benefited from mentorship to think about how we can pull up more people. Mentors have played an incredible role in my life, and I'm deeply grateful for this. 2 of them are in this room. I'm not going to embarrass them by asking them to stand up for applause, but thank you so much for all your support to me. Finally, as a young woman in global health, there is so much I have learned, and I'm still learning. There is deep-rooted misogyny, there's patriarchy, and there's other isms that could easily stifle our career. But do I focus on the problem, or do I rise to the solution? As a community of future global health leaders, we have a choice, and I choose the solution. I often choose to put my best foot forward, to learn, and to stay humble while at it, and be intentional about opening the doors for other women like me. Because there's just not enough of us yet, not enough African women in global health leadership. We must keep the door open for others. As we've seen from the debate that just ended, it's very hard to say what the future of gender equity would look like. But I think the path starts somewhere, and the foundation needs to be laid with my generation. Firstly, give young people opportunities and support them. Secondly, to young people, we need to go over and beyond the call of duty without a sense of entitlement. And finally, we must always think about how we can support others as we rise. Last night and today, we've had some of the best music from Nigeria, and so it's only fair that I end with a quote from one of our favorite artists, Davido, who's always saying that we rise by lifting others. Thank you.
Thank you very much, Ronke, for that excellent stirring call to action to support young people. And you do not want to leave the room because you have got to hear our final speaker. So, our final speaker is a colleague who I admire immensely, Dr. Mary Muchekeza from Zimbabwe. Mary is passionate about the delivery of safe, appropriate, sound, and equitable healthcare services to children, adolescent girls, and women, particularly those marginalized members of these populations. Her goal is to live in a world where all people are healthy and exhibit the best part of themselves in everything they do. Dr. Mary holds bachelor's degrees in medicine and surgery and a master's degree in public health from the University of Zimbabwe. She's a community health physician with a demonstrated history of working in various leadership positions in the public health domain in Zimbabwe. She's a fellow of the first cohort of the Kofi Annan Global Health Leaders Program. That's a recurring theme today and across the whole conference, and is also an alumnus of the Greater Leaders Program, a training and coaching program specifically focused on women and female leaders across the world. And Dr. Mary will talk to us about equity through the intersectional lens, reflections from the intersection of gender and physical disability, as a patient, an advocate, and a leader. Welcome, Mary.
Yeah.
Switch it off.
Good morning, ladies and gentlemen. Thank you for having me. I'm going to speak to you about a very weighty title, and I will repeat it. Equity through the intersectional lens, sharing reflections from the intersection of gender and physical disability. So as I give my address today, which I consider an advocacy statement, I'm going to be sharing reflections of my own, as well as those from the authors that I've come across. While attempts at addressing gender inequities in health started several decades ago, the progress has been very modest. Yet it is my strongest belief that if at all we are to achieve universal health coverage, then we need to stop looking at women as a homogeneous group and start projecting and listening to their unique voices as tools for developing effective global health solutions. Focusing specifically on gender to categorize health status is not universally accepted as the best analytical approach, particularly considering the complex interplay between a range of determining factors resulting in health inequities, bringing in the concept of the need to apply an intersectional approach to addressing these. Intersectionality was first coined by Kimberly Crenshaw, who pointed out that social justice is not always a gender or a race issue, but rather an intersection of factors that determine it. So using this theory of intersectionality contributes to our understanding of the experiences of women with disabilities in their unique forms and in different environments. For example, a woman who uses a cane sometimes and a wheelchair other times will have very little difficulty when trying to access a public office which has got stairs only. But I bet her experience will be very different when she comes back to the very same office using just a wheelchair and there isn't any ramp. Showing how an interplay of different factors can significantly change the outlook of things for the very same person. So I'm persuaded, ladies and gentlemen, that promoting and protecting the rights and dignity of women with disabilities and ensuring their full participation in healthcare is an integral part of the pursuit of the Leave No One Behind principle that is enshrined in the 2030 Agenda for Sustainable Development. While there have been important advances in addressing gender disparities to access to healthcare, there is still some way to go in addressing the multiple jeopardy for women with disabilities accessing the same. In almost every age group, women with disabilities use more health services, yet are less likely to have medical insurance to facilitate their access to this. And when it comes to gender-based violence, the intersection between gender and disability is a matter of serious concern. The risk of facing gender-based violence increases by many times for women with disabilities, with this abuse being perpetuated not only by intimate sexual partners, but also family members, personal care assistants, and even healthcare professionals. And believe you me, the violence can even take very subtle forms, such as deprivation of social events, deprivation of entertainment, and a belief that women with disabilities are not sexually active and hence do not want to fulfill the role of motherhood. But it's wrong, and it's not a fact. We also know that the gap in education for girls is already considerably large in general. However, this gap widens even further for women and girls with disabilities. And we know when access to education is limited, areas such as family, finance, nutrition, and health are put at risk. While some researchers have shown the contribution of women in healthcare, specific data on the contribution of women with disabilities as healthcare providers, formally or informally, is very scanty, if not unavailable. And I would opine that the paucity of such information is partly to do with the discriminatory nature in which organizations view women with disabilities as potential employees. Much as most organizations would put a caveat on their job adverts that they do not discriminate against gender and disability, they would rarely choose to employ a woman living with disability in actual effect, as this would often come with both actual and perceived extra costs in making sure that they optimize that individual to function optimally. The biggest concern is that this intersectionality between gender and disability and its effects on health is not fully appreciated by most in the global health space. It is thus not something that can be consigned to watchdogs in a single office or organization. It therefore becomes a call for the whole global health community to start thinking seriously about focusing the gender and disability intersectional lens to promote health for everyone. Moving on to leadership. While women in healthcare leadership have seen progress over the years, the gender disparity for women with disabilities in the same space remains glaringly big. Granted that the playing field for leadership in the healthcare industry continues to shift, women in general still struggle to break through to the higher levels of healthcare. And with this low representation comes the mistaken perception that women can't or shouldn't lead. I would shudder to think what that would mean for a woman living with disabilities becoming a leader. Now, imagine the odds for a woman who was born with a disability even becoming a healthcare provider, let alone a leader. Women with disabilities are expected to work in systems primarily designed by and for traditional normal roles, life patterns that are broadly detrimental to social, economic, and health outcomes. Ladies and gentlemen, this calls for a 360-degree systems and mindset change on the part of all players in the global health space. As Kofi Annan once said, when women thrive, all of society benefits, and succeeding generations are given a better start to life. Allow me, therefore, to sum up by making the following concluding statements. First, society has generally been designed with the exclusion of women with disabilities. Hence, it is imperative that we approach research through an intersectional lens to inform policy formulation. Second, there must be a continuation to empower women with disabilities, demanding the inclusion and amplification of their voices in the design of policies, not the voices of those who think they know what it is to live with a disability, as often happens. Third, we must eliminate the disabilist belief that women with disabilities are less capable, have got less rights, and start viewing disability as potential ability when aided by the necessary support systems. Fourth, it is simply not enough to have policies to support women with disabilities on paper, as often happens. This is a call for actual action to the global health community to bring policies into life, as indeed the life of any policy lies in its implementation. Finally, we need to employ an intersectional approach to the thinking, the planning, and the provision of services that would transform the lives of women with disabilities and would optimally promote health for everyone. Maybe, just maybe, that way we would be one step closer to making the universal health coverage dream a reality. I thank you. I'll move that.
Sadly, because we are way out of time, we're not going to be able to take any questions. So I would just like to bring our session to a close. And I'm just going to ask our panelists and speakers to stay so we can take a picture at the end of the session. So, Excellencies, honorable guests, colleagues, ladies and gentlemen, members of the African public health family. Today, we have heard amazing speakers, and I have loads of notes taken that we don't have time to get into. So you've all heard, starting with Professor Kolsek, Minister of State, where she said that she spoke on the initiatives to mainstream gender equity in health, raised the issue about the fact that it is not a competition. We need all hands to work together. Dr. Magda pointed out that women are often in the background and we need to create an environment that enables them to step forward. We need to have, Dr. Mwanzi said that we need to have women in charge of the storytelling. We need to have women driving the health messages. We raised the issue of a challenging the patriarchy in their role in, and the necessity to change the patriarchy to achieve the improvements in the health agenda for women. We need to identify mechanisms to move women from unpaid and underpaid care so that that underpaid care should be part of the system for assessing global economic development. We were charged to give young people a chance. And finally, our final speaker reminded us that women are not a homogeneous group and that we should view disability as potential ability when aided by the appropriate systems. So you will have noticed that this entire plenary, moderators, speakers, debaters were all women. And this was deliberate. We want to showcase a selection from the rich pool of amazing women we have in health in the continent. We have shown you youth, maturity, and diverse physical ability. And I ask for applause for their representation in this plenary. And I challenge the organizers of the Conference on Public Health in Africa. Last year, the first conference, we had a side event. This year, we've had a plenary of 90 minutes. Next year, I challenge you to give us a whole day. So it has been my pleasure to host this plenary, and I'd like to thank again all my speakers and you, audience, for listening and participating. Thank you very much. So please, if the speakers, we are adjourned. You have a few more minutes for your coffee. You have a few minutes to catch your coffee before the next plenary. Thank you all very much.
Ladies and gentlemen, we kindly ask you to leave the headsets on your chair. Please leave the headsets on your chair. We'll go around collecting them. Thank you. Ladies and gentlemen, we kindly ask you to vacate the stage as we are getting ready for our next session. We invite you to take the networking into the coffee area. Yeah, turn them off. Ladies and gentlemen, we kindly ask you to vacate the stage area as we prepare for our next session. Thank you. Ladies and gentlemen, we kindly ask you to take your seats as we're getting ready to start our next session, Whole of Society, the Power of Engaging Civil Society, Common Actors, and the Private Sector. If you are joining us for this session, we kindly ask you to take your seats, please. Music off, music off, music. Hi, Cruz here. How are you? Tana? You're here yesterday?
I was here yesterday. I just casal, disse não tá errado.
Oh, I'm quick moments.
How are you?
Hello, Tana? I now call upon Dr. Amit Thakur to take the podium and start us off with the session.
Good morning, everyone. It's a real pleasure to welcome all of you for the Track 7. And I'd like to thank Kedest and Monique, who are my co-chairs, who put a lot of work in getting this track on Whole of Society together, assisted by Sarah O'Brien and Esther Onyango, who diligently made sure that we truly had the Whole of Society represented in our track. One of the pillars of the new public health order is action-oriented, respectful partnerships. As you have all noticed, that the new public health order is going to be the main driving force on how partnerships will evolve and how we'll be able to change the health narrative on our continent. At the opening ceremony, all about the new public health order was revealed by Africa CDC Acting Director Ahmed Ogwell. What does this really mean? And what have we seen in the last few years about partnerships? I think partnerships have evolved quite rapidly. And in the last 5 years, the work that I do at Africa Health Business has seen partnerships take a different form of engagement. Let me explain a few trends that I've noticed and also explain how we will come together to transform the health sector on our continent for the better. I must mention one thing as we were putting the Whole of Society together as a team. It's now time that we document all our health partnerships in Africa. After careful research and extreme engagements with all the partners, I realized that the health partnerships in Africa for impact index does not exist. Looked everywhere for it, asked several institutions and organizations, but many of you present here today are doing some amazing work through partnerships. What does partnerships really mean? Partnerships is when two or more organizations come together for a common cause and offer a solution product or service that improves public health. So obviously, partnerships are going to be broadly classified as public-private partnership, public-public partnership, and private-private partnership. During the pandemic, it was quite clear that all three types of partnerships played a role in saving lives and livelihoods. At Africa Health Business, we have been really busy creating, managing, and forming these kinds of partnerships. And I'm glad that we have a great speaker lineup today that are going to share experiences from all subsectors of the health industry, including the NGO space, the development partners, the private sector, civil society, and others. As I conclude on setting the stage for this wonderful panel that will be moderated by Kedest, let me share with you what I've noticed as a trend in partnerships for healthcare for our continent, and how I believe we all will play a part in transforming health. The first trend is that partnerships are on the increase. In September, you all read about Unstoppable Africa. That provides you a $259 billion opportunity in Africa in making the continent's healthcare more robust and resilient. This $259 billion opportunity makes us, by 2040, only the second leading market across the globe to United States. Africa will hold 14% of the healthcare opportunity, while US will hold 21%. This Unstoppable Africa is going to create 16 million new jobs and will be the second highest growth industry on the continent, providing meaningful jobs also to the women. But this could not be done and will not be done if we all work in our own silos, in all vertical programs, and not harness the diversity of the variety of stakeholders that are in the room today to come together and make the difference. So I have noticed that partnerships are on the increase. I've also noticed that partnerships, even in commercial private sector where I am, are not only thinking about the commercial gains, but of the common good on how health will improve on the continent. I have seen NGOs, CSOs, and governments and ministries of health coming together to form meaningful partnerships to take advantage of the diversity in changing healthcare. The second trend that I've noticed is there are only two types of partnerships that I've seen in healthcare that's changing our continent's landscape. It can either be a selective partnership or a non-selective partnership. Selective partnerships are organizations that come and form partnerships, consortiums that focus directly on their needs or their interest areas. It could be maternal health, could be family planning, could be digital health, could be academia research, could be telemedicine, and so on and so forth. Let me use one example. It's quite amazing how digital health providers across Africa, even yesterday, came together under a network of the Pan-African Digital Health. Why? Because 20% of consultations in the US, if you take Medicaid and Medicare, are being harnessed under virtual telemedical care. In Africa, we are still around. So if we are told that the $250 billion market in virtual telecare is going to be there, we need to forge partnerships that are meaningful and effective. So finally, as I conclude, what's next for the whole of society and partnerships for health? We will hear from the experts today. We will hear what we could do in forming the Partnership Health Index in Africa. How can you, as an organization, get involved in more meaningful partnerships? How does your entity have a multiplier effect in the work that we do so we can become the Africa we want, leaving no one behind? Thank you so much. At this point, it's my pleasure to invite our keynote speaker to talk to us a little bit more about partnerships and insight. Please join me in welcoming Omar Sheikh Saidi, who is the Africa Director for Global Development with the Bill and Melinda Gates Foundation. Please welcome Omar.
Thank you very much, Amit, and thank you for sharing those trends. Senior government officials, the acting director of the Africa CDC, my brother Ahmed, co-chairs of the conference, and also co-chairs and panel members of Track 7, partners, distinguished ladies and gentlemen, with all due protocol observed. Good morning. I'm delighted to join you in Kigali to reflect on our collective accomplishments over COVID-19 pandemic and the power of the whole of society approach in combating the biggest public health crisis we have faced in recent memory. This is also an opportunity to reflect on the lessons we can take forward as we strive to build resilient health systems to be able to face any future challenges. As we've all experienced, the last 2 years have been immensely challenging on our economies, on our health systems, on frontline healthcare workers, and not least of all, on our communities. Despite these challenges, we've learned several important lessons, including the importance of partnership that Amit was just referring to now, and collaboration, which I want to focus on this morning. Governments have been hailed throughout this continent for the remarkable achievements while having very limited resources. So those are the headlines that we've heard the most, and they're real. So today I wanted to take a moment to highlight a few stories that relate to the strong private sector, civil society, and community-based partnership that I believe need to be told a little bit more often. So Amit, I will not talk about the DFIs, those partners, because these typically steal the headline. And since I had only 15 minutes, I had to pick and choose. And there I will say that my bias on the stories are on the stories that I'm familiar with by virtue of my work and our foundation's involvement. But let me also say that there are many more stories out there that exhibit the takeaways and perspective that I will be ending with today. As most of you recall, when the pandemic hit, most African countries were struggling to obtain essential PPE and oxygen equipments on the global market. The crisis did demonstrate at the time, and continues to, the challenge that we had in relation to coordinated, centralized purchasing platform for life-saving commodities, but also the fact that we were not producing them. So our health security was threatened. This led to the creation of the Africa Medical Supplies Platform, known as MSP, which helped provide another avenue to access essential COVID-19 supplies, including PPE, therapeutics, alongside, and I want to clarify that too, existing chains. Those are supply chains such as the likes of, provided by the likes of UNICEF, and also financing partners such as AfriExim. The creation of IMSP was an exciting and collaborative innovation supported by the African Union that leverage private sector solutions with strong leaders such as Strive Masiyiwa. It unlocked additional access to an African and global database of vetted manufacturers and procurement partners and enabled the AU member states to purchase certified medical equipment, therapeutics, and diagnostic with increased cost efficiency and transparency by using an e-commerce platform. In addition, by enabling countries to pool orders and benefit from economies of scale, it saved both lives and money. AMSP also played an important role as a logistics and distribution partner in securing much-needed vaccine for the continent. Again, this is on top of what was existing at the time. AU member states were suddenly given an opportunity to purchase over 1,000 COVID-19 related items, many of which continue to play a critical role in new disease outbreaks that our continent is still grappling with. At the country level, we have an incredible example of a whole of society response in the form of South Africa's Solidarity Fund. Established by the country's president as a rapid response mechanism to leverage the private sector, civil society, and philanthropy, and run by a fully pro bono team, and I repeat that, it was a fully pro bono team, the Solidarity Fund was able to raise $260 million from philanthropies, local corporations, and over 350,000 ordinary citizens, including through salary contributions from individuals. So a real grassroots effort. Newly formed and unprecedented in scope, the Solidarity Fund moved rapidly to augment the South African government's response to the COVID-19 pandemic, providing much-needed financial, technical, and strategic surge capacity for a rapidly evolving health and, of course, an economic crisis as well. Interventions ranged from supporting mass media campaigns that reach more than 90% of adults in South Africa, funding essential initiatives for COVID-19 vaccination, tackling the upsurge in gender-based violence seen in the country at the time, to delivering food and cash vouchers to over 280,000 households that were in need. The Solidarity Fund is one of the top 10 funded civil society-led COVID-19 vehicles globally, offering for many of us inspiration as well as valuable insight into the establishment, development, and ongoing operation of an innovative approach to emerging public-private partnership. Another great example at the country level can be found in Nigeria in what is known as COCAVID, the Coalition Against COVID, which is a private sector initiative led by prominent business leaders in partnership with the federal government, Nigeria's CDC, and WHO. The coalition proactively targeted corporate networks and raised close to $80 million that helped build and equip facilities and labs to provide testing, isolation, and treatment centers, as well as training of healthcare workers. Set up to work with and through the government, COCAVID has provided food and other commodities and also procured and supported the distribution of COVID-19 vaccine to all states in Nigeria. At the community level, we saw unexpected partners, I would say unexpected partners coming together to address a shared humanitarian crisis. Uber, for example, partnered with the provincial government in South Africa to ensure that patients on chronic medication, such as those suffering from NCDs and HIV, could continue to access their life-saving medication when health facilities pivoted, and that's a story we've seen throughout the continent. And they pivoted to COVID-19-centric services at a time when public transport ceased during the lockdown, making accessibility to routine clinical services challenges. Very challenging. Those were very difficult times. And in fact, with those actions, the transmission that was feared reduced significantly. And the surplus capacity on the Uber platform was successfully redirected to deliver chronic medication to define meeting points in communities where community health workers could walk the last mile to take these medications to patients' home. It made a huge difference. And then at the end of 2020, after 8 months of intervention, a total of 1 million medicine packages were successfully delivered to those patients. This program is now being scaled to become a sustainable element of community healthcare. Again, a benchmark was created because there was a need, there was an emergency, and people came together in the same spirit that Amit was talking about earlier. COVID-19 also ignited cross-sector partnership between the tech industry and the health community in many countries in the world. And so that would be my last example, and it is noteworthy. And in this case, I want to talk about Babil here in Rwanda. It is now Africa's leading telehealth service. It used innovation to help place accessible, affordable digital healthcare services in the hands of citizens. As Rwanda worked very hard to provide equitable access to primary healthcare services during COVID-19, Babil reworked its digital health platform to close the health gap and ensure that 2.3 million users could receive advice on COVID-19. They built a platform that was compatible with any phone so that it was affordable and accessible in the same manner to everyone, including in rural areas. When we talk about something being fit for purpose, it has to account for the needs of the people you're trying to serve. This new technology was pivotal in relieving Rwanda's health systems as it provided a cost-effective solution for enabling those who were critically ill to be admitted in hospitals while everybody else could be treated from home. By 2021, Babil's health services was integrated into the national health system, and over 20% of Rwandan adults population signed up. So yes, it was demand-driven. There are many other examples that I can cite today, such as the collaboration effort that led to the Institut Pasteur of Dakar producing the $1 COVID. You may remember those headlines. Those are the $1 COVID diagnostic at the time it was most needed. I can also talk about the donor collective that united many of us, philanthropies and other organizations who felt that it was important to thought partner with the Africa CDC, and that partnership continues. But let me end by just talking about a few takeaways and things that were, in a way, common in many of those examples. I'll start with a bias by saying that the private sector is a big part of the solution. We sometimes talk about it, but I wish we could talk about it more often. And this is critical at these unprecedented times when I think about the fact that our economies are just emerging out of COVID with a significantly reduced fiscal space. And this is compounded by a debt crisis that many are experiencing and the reduction of official development assistance, and also, as you all know, the unfortunate negative impact of the war in Ukraine. The other thing I wanted to highlight, it's about leadership. Leadership matters. Whether you're in government, in the private sector, at the community level, or anywhere else, because that's what it takes to get these initiatives going. In these cases also, complementarity, shared vision, and willingness to collaborate exactly just the way you were explaining it earlier would matter and did matter. Flexible funding, especially at a time of crisis, also matters. Let me stay a second here. We've all seen it over the past 2 years or so. There's been many, many announcements. But if you look at all of those announcements, they did not all translate into actual disbursements. And when you are facing an emergency, that's first catalytic funding that get everything going is critically important, and we've experienced that. That's a lesson learned. So in other words, the way you finance those operations can go a long way toward determining how far you go. And then the last one I really wanted to also spend a minute on. It's about being able to achieve what I call self-reliance. The pandemic hit, everybody was in panic. We were looking for things that we could have produced. Now, you're going to hear a lot of narrative about, oh, every African country wants to produce these vaccines. It's a false narrative from my perspective. Let's be real. There are those who can get us going. Let's start with them so that we have something to begin with and build on that. Why? Because it's a matter of health security. It is not a luxury. And I attended last year's conference when everybody was busy talking about it. And I just hope that that momentum does not just evaporate, because it is real. You have to start with something, and you cannot always be at the back of the queue. That's the big dilemma we'll face with respect to equity during this crisis. And then as we look to the future, tomorrow belongs to those who prepared today. So it is critical that we seize the momentum gained during the pandemic and intentionally create opportunities to work together to address fragilities in our health systems and ensure that we put in place the necessary infrastructure, resources, and capabilities to effectively prevent, detect, and respond to the next pandemic or public health emergency. Thank you for your attention.
Let's put our hands together for our keynote speaker, Omar Saidi. I wouldn't go into summarizing what he said, because at the end you will get some closing remarks from Monique Wasuna. But what resonated with me as Omar came through is these examples. And Omar, your examples were wonderful. You also ended up with the Babil example. And I would like to urge that when we do come for the next CPHIA, we talk about the Partnership Health Index for Africa. Somewhere where all of us can benefit from learning and reading examples of AMSP, Babel, and many others, and we replicate this and move ahead in delivering solutions. I also heard about leadership matters, and I heard that self-reliance is the way we go. And we totally agree we need to think of moving away from donorship to ownership, and we can think about trade and investments for our growth and self-reliance. It's now my pleasure to invite the moderator for the panel that we will see now, Kedest Tesfagiorgis, the Director of Global Partnerships and Grand Challenges from Bill and Melinda Gates Foundation. Please welcome her with an applause as she walks with her panelists. Kedest, over to you.
Good morning. Thank you. I think Amrit just promoted me to director. I'm a deputy director for Global Partnership. Good morning. I apologize. I lost my voice, but I'll do the best I can. Good thing I'm a moderator, and we've got some fantastic speakers here. So my job is really to guide the conversation and not speak. So all good. So we have 35 minutes for this section. I would love to keep a time so we can involve and hear your stories of partnerships, because we're here to learn about all the creative ways that we can move our collective work. Omar started us with fantastic stories. Amit, you told stories. And to me, I was raised by my grandmother. She was a fantastic storyteller. I see storytelling as a really good way to connect as human beings and to connect all our collective work. So I also see the whole of society means the essence of whole society is really at the engine and at its core. It's about working together and partnership. So our entire session that we have planned is really about how we can learn from each other to move forward this very difficult task that we all have ahead, and taking advantage of the awful 2-3 years that we all went to as a global community as we dealt with COVID and everything else to move our collective work forward. So I think you're gonna meet some fantastic people who are leading some incredible work in different parts of Africa. You all come from different perspectives and different expertise. So we're really looking forward to hear. So Moses Alobo is the program manager of Grand Challenges Africa. Mokdi Mishishi, she's a business unit director at Organon, and Jidane Dilly, she's country director at Pharma Access Foundation. So thank you very much for taking the time to join us, and here we go. So we've got a timer right here. We've got 35 minutes to tell our stories. And then ideally, folks who have some questions or comments or have some good things to share, we're going to come at you in about 32 minutes from now. And our colleagues here will tell us how to process those questions. So for all my panelists, I'm going to start with you, Moses, and then the same question goes to all of you. The COVID-19 pandemic really did teach us a lot of lessons, some of them awful and painful, but some of them are actually incredible human stories of resilience and creativity. So can you please, each of you, share a little bit about what you do and how you adapted in those early months of COVID to continue the work that you do, because frankly, a lot of the work has advanced in progress despite the pandemic. So I'm really curious to hear your thoughts. So Go ahead, we start with you and then we're gonna go.
So thank you, Kadest. Absolutely excited to be in Kigali. When I walked into the airport, it was interesting to see an introduction saying, welcome to the land of doers, which was really nice. The interesting thing and the question that actually came to me at that particular point in time when I was reflecting about this particular panel is, what is science doing for the African continent? Because I do come from an organization called Science for Africa Foundation, and me and my team run a group called Grand Challenges Africa, where we do translational sciences, and we also do transition to scale, picking ideas from scientists and making sure that they go through to market. So if I was to begin with COVID-19, it was a really interesting time. It found us, being a science funding organization, it found us not having funds or money kept aside for a pandemic or anything like that. It was an interesting challenge. We really had to start with repurposing some of the funds, small little funds that we had as we went through fundraising. So that was an interesting time. So question that we are currently asking ourselves in the inter-pandemic period is, what else can we do to build a surge capacity for funding issues or epidemics that will absolutely come when we are not ready? But at the same time, could I just say that we also learned that African scientists have the absolute capacity to contribute to global health issues. I mean, if you think about Omicron and any other variant of interest and concern that was actually identified on the African continent, it tells you a lot about how developed African scientists have actually come. And then could I just say that investments in science over the last maybe 10, 20, 30 years are the ones that helped African scientists be able to respond to the issues that were there. So I think this will be my opening remarks, Kedes.
So thank you so much. Again, it's a pleasure for me to be here. As I was introduced, I'm the country director for Farm Access Foundation, but I wear a couple of hats. I am also the vice president of the Healthcare Federation of Nigeria, which is an advocacy body to ensure that private sector is included in providing healthcare services within the country. I am also one of the commissioners for the Financial Times and Lancet Commission that was set up for, to explore how digital and artificial intelligence can be used to accelerate UHC, especially for low-income communities and for the youth. So, of course, when COVID struck, there were stories of how Africans are going to be dropping dead on the street because of lack of access to healthcare services. As Farm Access, what we do is really support state and federal governments within Nigeria and in 4 other African countries, actually 3 other African countries, to work towards universal health coverage, especially for low-income communities. So it was very easy for us to quickly adapt. So I'll give just 3 concrete examples on the 3 different tracks under which I implement my activities. So on the Farm Access side, the first thing we did, because we actually work with a lot of partners, Farm Access is supported by the Ministry of Foreign Affairs of the Netherlands, and this is to aid their trade policy, providing technical assistance to strengthen the healthcare system. So the first thing we quickly did was to begin engagement with some of already existing partners like the FCDO, the Foreign Office, Commonwealth Office of the UK, because we were already implementing some projects in the north of Nigeria so they could repurpose some of their funding. And part of the work that we did was quickly to do a landscaping of private sector labs that could do the testing, as at the time it was just public sector, public facilities that could test for COVID. So this was a quick way to identify private sector labs that could support the government so we could ramp up testing. So that was the first thing we did. Second thing is that we quickly started engaging providers through webinars. We conducted, in fact, it was a bi-weekly webinar just to educate, for people to understand what COVID is, and that it's not a stigma. How do you take care of yourself, especially healthcare workers? So we were able to reach over 5,000 participants online. So again, this was the power of digital. The third thing, what we did was to begin to develop simple tools. We talk about Africa and how we can leapfrog. Nigeria, for example, has over 100, and in fact, as at the last count, over 200 million active phone lines. So you can imagine the power of this equipment. So we then thought about how can we develop simple apps that can be used and really decentralized. So we came up with the Safe Care for COVID app. Safe Care is a quality improvement methodology that was developed by Farm Access in collaboration with COSASA and JCI. But then it can be used by the healthcare providers to assess their readiness during the COVID pandemic. So that was on one track, but there were so many other things we did. On the second track, working with Healthcare Federation of Nigeria, we really became active, and this is now engaging government. The private sector is in the room. Private sector can support the work government is doing because they can't do it alone. In Africa, over 60% of care is provided by private sector, yet most of the facilities are government owned, and they're empty, there's nobody utilizing it, and they're defunct. So the situation then is, how can we partner and get private sector in the room to provide some of the services? So, I mean, it goes on, and I could take a whole day talking about what we did. But ultimately, private sector has a seat at the table. We utilize this time of COVID to make our presence felt. We are stronger as an organization, also collaborating with AMIT to make sure that we have a seat at the table so that we can push private sector efficiency, transparency, and initiatives forward. And last but not the least, talking about what we did with the Lancet. The Lancet Commission, we finally, after so many encounters, so many deliberations and collaboration with different partners, including WHO, youth organizations. I heard the lady talk about the engagement of youth. We recognize the fact that the systems of today and the systems of the future need to have the involvement of youth, because ultimately this is the system that they will inherit. So we have analog leaders designing a digital system for the future, and it's not going to work. So we made the effort to develop a report which then is a building block or indicates what countries need to do, regardless of where you are in terms of your journey towards UHC. But what are the fundamental building blocks that would enable you to achieve UHC using digital technology? And that report was launched last year, and it's on the internet for those who are interested to read about it. But I'll end here for now, because there's just so much when you talk about partnerships and collaboration that could happen. Thank you.
Good morning, ladies and gentlemen. It's an absolute pleasure and a privilege to be here in the city of 1,000 hills. In South Africa, we also have the land of 1,000 hills, so that I found quite interesting. But I'm Mohadi Mashishi. I'm the business unit director for our business outside of South Africa for Organon. So this includes Institutional Business Africa, where we provide access to family planning and other commodities across 33 African countries, and we are in partnership with organizations like the Gates Foundation, UNFPA, and many others to ensure that women on the continent have access to safe, quality contraceptives, among others. And then we launched our organization, Organon, in 2021, last year, June, in the middle of a pandemic. And when we launched, our intention was not only to launch a company, but also to launch a commitment to women's health. And our mission is to provide we envision a better and healthier every day for every woman. And in terms of partnerships, for us, we see it as the key, really, to achieving the solutions that we're looking to achieve in healthcare. So we work with multiple organizations, as I mentioned, to build capacity of healthcare workers across the continent, but also to drive education of the youth and all the other community members when it comes to sexual and reproductive health. We also create awareness campaigns around multiple disease areas, including non-communicable diseases. And we continue to look at pipelines that will ensure that we do have solutions. But for us as an organization, we also want to go beyond the pill. And I think the Institutional Business Africa is one of those elements that we use to drive exactly that, where we're working with donor funders, with implementation partners, but also social and marketing organizations to ensure that access to family planning and other healthcare services can be achieved right at grassroots level. And when we launched, we also felt that it was important to amplify the voice of women. And I think on the African continent, where women constitute over 51% of the population, this is absolutely key. And we cannot have clear healthcare solutions without ensuring that women are right at the center of it. And I think as we look at whole society approach, we need to also appreciate the impact that women have on societies, especially as they are the cornerstone. Therefore, their voices have to be heard. And one of the things that we launched was a wall of voices, where we invited women across the globe to participate and share with us what were some of the challenges that they felt needed more attention, so that as we think about our pipeline, then we can start to encourage as well, or rather develop medication that is directed to solving the problems that women have brought to the table. And I think, given the nature of women, we are people who love to engage, right? So bringing them onto the table, someone mentioned the table yesterday, that they were told that build the table. So we learned that it's important as well to bring your seat on the table. So again, in the spirit of nothing for us without us, we are really working hard to ensure that they are part of the conversation and part of the solution and the co-creation.
Thank you for that.
Thank you.
All right, so Moses, can you guys hear me? I was told that I needed to switch, so let us know if you can't hear us. Moses, I wanted to pick up on one of your comments, and by the way, again, we could have spent 3-4 hours just talking on some of the things that you have done. My hope is that any interesting bits and pieces after our session, please come find our wonderful speakers. So we're gonna keep moving on so we can cover other things. But Moses, I wanted to pick up on what you said about African scientists and the incredible work we continue to see, that we've always seen, but we continue to see, and more and more the world is seeing. Can you talk a little bit about, most of the time, because of how we are, how the universities are set up, a lot of our African scientists are incredible knowledge generators. There is a lot of things that come out of this continent that's from the academic side that we hear about. Could you speak a little bit about the work that you're doing within Grand Challenges Africa or any other organization in Africa that you know of to increase the partnership so we could not only be knowledge generators, but also translators of those knowledge into products that our communities could use here at home? So just maybe you can talk a little bit about that.
Not yet? Yeah, that's better. Okay then, so let me just introduce you to my world, or our world, for you to just have a view of it. We put out approximately 5, thereabouts, let me use 5 as an average, calls for proposals every year as a group. And when we do that, we receive a total of approximately 2,000 applications. Now, 2,000 applications means that in it, you've got scientist groups that have formed partnerships, and then they've sat for 6 weeks, they have put their ideas down on paper, and then presented it. Now, multiply that by 2,000, okay? Now, when that comes through, in terms of our funding, of course, we cannot fund all the 2,000. We have to pick, cherry pick, so to speak, peer-reviewed, of course, from peer reviewers all around the world, to see which ones are best aligned with the priorities that are there on the African continent. At the same time, just a tidbit, we realize that most of the applications that usually come, well, not most, but some, actually come with a biotech attached to them, meaning therefore that the biotech industry on the African continent is actually developing, to the extent that if someone goes to do a postdoc or a PhD outside of the African continent, when they are there, they get the support to actually register their idea, an IP, register a company, and then after that, at some point, they decide we need to go back to the African continent. Now, when they come back to the universities, they do not get the support that they were getting in developing the idea, in making sure that their particular idea actually goes to market and it's translated. Now, what we see, and again, apologies to, if you're a vice chancellor or a dean of a university seated here, but what we see that is given to those particular scientists is what I call a knowledgeable support, okay? To the extent that, yes, there are people who are trying to do something, but it's not enough for those particular scientists and their ideas on public health, on UHC, on primary care. It's not enough for them to actually take it to market. There's a certain gap because at some point, private sector usually tells us, we want to invest on some of the ideas, some of the groups that you're supporting on the continent. But unfortunately, when we present some of those particular ideas to them, they say they are not developed enough. So the question we now ask is, are we able to actually build an accelerator for scientific ideas on the African continent that can actually be able to bridge that gap? So that's what we see. The other interesting thing, if I may just mention quickly, is that if we are to get other groups on the continent interested in what scientists are doing, then we need to de-risk their entry into this particular group that we do present to them. So that is what I would say.
Great. Well, thank you. So I guess the question is, most of our universities are publicly funded, at least here. So it begs the question is, what, the role of government, given that they have so many other priorities to do, but we still need a little bit more support, whether it's in de-risking or whether it's filling in the gap of acceleration that you've talked about, or the lack thereof. So I guess I'm going to come to you ladies in terms of your experience or expertise or tips and from your world that you have seen on the role of government or the gaps of role of government and where we need to be in order to translate these amazing ideas by amazing scientists into actual products.
Okay, I think as you were speaking, an innovation of ours came to mind very quickly. It's called the Mobile Application for TB Screening. Some of you may know that Nigeria is among the top 10 countries with the highest incidence of tuberculosis, but yet case finding is very low. In collaboration with Global Fund, we received a grant that we used to develop a simple application on a feature phone. Basically what we did was take the algorithm or the procedure for the questions you ask and translate it into an algorithm on a phone. such that it can be decentralized, taken to community health workers so they can use it to screen people within the community, of course, because of the stigma attached to tuberculosis and people visiting the hospitals. So when you talk about two things, I want to connect. One is the role of government, and two is the role of simple technology and partnership. So basically what we did with this small funding from the Global Fund, we developed this app, but in collaboration with the National TB Program. So we were keeping them abreast of what we were doing, in addition to another NGO, which was a recipient of Global Fund, but they weren't too sure. In fact, they were the main recipient. We were like a sub-recipient, you know, the hierarchy of developmental funding. But ultimately, where we are now is that this MAT tool has been adopted by 22 states in Nigeria out of 36 states plus the Federal Capital Territory. In less than 1 year, we have been able to screen over 1 million people on the app and identified TB presumptive, which are, of course, triaged to treatment centers. The reason I'm using this example is that, first of all, the role of government cannot be underemphasized, because for sustainability, long-term, they need to have the policy in place, or the policy environment, or also provide the kind of policies that encourage private sector to participate and come forward with the innovations. Without a doubt, the knowledge and the innovation, the risk-taking is in the private sector. So how do you form that partnership with government to be able to allow them to either take the glory for the innovation or to take it forward? So the point being that partnerships count. In fact, if I have to remember all the partners that made this happen, I have to look at my phone, because I have the government at the federal level, which is, the overarching governance body. I have the state TB program officers as well, who you have to work with and make sure that they adopt the tool. You have the developers, which we engaged. You have the community health workers, which we shouldn't also underestimate, because they have to understand the role that they're playing so that they're able to utilize the tool in an effective way and bring back the results. So again, just to mention that collaboration and the role of government is very, very key for long-term sustainability and scale-up of any innovation that has been put forward by private sector. So it's very key for us to make sure that we recognize their role in this environment.
Right. And Mogidi, any stories you want to share in terms of your own work in partnership with governments?
Yes, absolutely. So I think, one always has to look to remember that government is actually the steward of ensuring that there is proper health care for citizens, and they need to then create an enabling environment that is less red tape focused, but enables those partnerships that are critical to actually happen effectively. And I think, we have had great engagements as well as great partnerships with various governments in the countries in which we are present, where a lot of talk is now about moving from being specifically focused on being funded, but moving to more self-sustainability. And I think that was also one of the key things that have come through in the conversation during this conference, which is quite encouraging, and also hearing the responses that most of them have had. I mean, for me, the most impactful one that was shared yesterday was that intentional investment in healthcare by Rwanda, right? That 15% that was intentionally put aside to ensure that healthcare remains a priority. And I think if more and more governments move in that direction, then we are a step closer to winning in this space. But also create an environment where partnerships are not, too stringent or difficult to have. So, and in terms of academia, coming back to your issue around the young researchers, I think it's important for all of us to realize that these young researchers are the leaders of tomorrow. So how do we ensure that the research that they come up with is protected? So that intellectual protection still remains critical. And how do we ensure that they can also partner with private sector to ensure that their research or their discoveries can actually see the day of light, right? So we have quite a lot ahead, and it's also interesting that there's a lot of technology that is conceived in Africa, but then ends up being refined elsewhere, and then we have to buy it back as Africans. And I think that's something that we really need to work together, and that is why we keep saying that to push the agenda for healthcare, we need multi-sectoral collaboration, we need multi-stakeholder collaboration. So every single sector has a responsibility towards improving healthcare and ensuring that we can achieve the goals that we have to have universal health coverage.
Thank you. So we've got 5 more minutes, and I've got a set of questions for you guys. But for our audience here, I'm going to open it up in about 5 minutes. If you have questions, please find some of the mic runners in the back, and we'll try to get them. So I guess, let me start with you, Jay. What are your top priorities, let's say, this coming year? In terms of expanding and boosting your own partnership work?
So my top priority really is to find a way to collaborate more with existing either donors or government, or deepen the relationships and the partnerships already. In fact, there's 2 phrases that I use. One is start private and grow public, because ultimately it is for the public. And 2 is to find a way to horizontalize vertical programs. Ultimately, we are trying to achieve universal health coverage, and that is focusing on the whole human being as opposed to one disease ailment. So I know it's a tough change in the mindset of donors and developmental partners, but that is really where we need to go, because we need to stop replicating structures and find a way to leverage the funding so that we all, ultimately, we're trying to achieve the same objective, right? Which is the wellness of one human being, the coverage, access to care, good quality care of that individual, especially for the low-income community. So really, that's my goal. So I'll be preaching, collaboration, pharmaceutical companies, government, other donor partners. Let's look at what our objectives are. Let's see how we can align our resources so that there's reduced wastage. Like the African proverb says, if you want to go fast, you go alone, but if you want to go far, let's go together.
Exactly. Thank you. So in other words, leveraging what we already have, not duplicating efforts, and trying to do as much as we can to connect the dots so we can deliver on our work. So what about your priority for the coming year?
So we have recently, working with AHB and in partnership with Hologic and BD, we have recently launched a coalition for women's health in Africa. And that's exactly to do what you've mentioned now, in terms of looking at the priorities in women's health, looking at the fact that there is so many great initiatives, but because everyone is working in silos, the impact is not as magnified as it should be. So we launched this in November, and we anticipate it will help us to streamline the solutions and ensure that the impact can be much more heightened, and also to amplify the role of the public sector in public health, in resolving public health issues.
Thank you. Thank you. And Moses, what are your priorities for the coming year?
So top priorities is to build capacity in critical areas of science. So for example, genomics medicine, drug discovery, data sciences are some of those areas. Plus continuing with the other support, HIV, malaria, TB, in terms of infectious diseases, but also start thinking about neglected tropical diseases as one of those areas that I think need absolute assistance. But for us, generally in the long term, we want to encourage and support groups to build capabilities that are currently held by commercial groups outside Africa. What I mean is there are a lot of proprietary databases that if you are to develop a vaccine, if you're to develop a drug, or any other invention in engineering, material sciences, mining, anything else, there are proprietary databases that you actually need to check your signals in. And unfortunately, these particular databases are not currently held and or maintained on the African continent. Therefore, we need to be at a place where we are actually doing and building these things in the long term. So investments in those kind of ideas are some of the things that we are looking at. But finally, we would like to have a look at global health priorities and then try as much as possible to localize them so that those global health priorities are actually making sense to the local governments so that the governments can actually come in and support.
Great. So those are great priorities. I think we all, what you spoke, I'm sure will resonate to the audience. So thank you for that. So do we have any questions? It's very difficult to see because of the light. So I don't know if we have questions. I'm going to give it 30 seconds to see if we have questions. If not, we'll go. Do we? Okay. Go ahead, please.
Hello, can you hear me?
Yes, we can hear you. Thank you.
Okay, my name is Fatima Ahmed. I am from Somalia. I wanted to ask the panelists, how can private sector combine the profit-seeking purpose and ensuring that everyone gets health? Because we sometimes see like health is for all, but health is for somebody who can get the money. So how can they balance, and what recommendations could they say? Thank you.
Fatma, sorry, could you repeat your questions, please? We heard the first part, but we didn't really hear the second part.
Okay.
Thank you.
Thank you. My question is mostly in the private sector. When it comes to health, it's sometimes for profit-seeking, and they couldn't, if the person cannot afford health service, they could not deliver it, and they would say, like, we can't give you. But how can they balance the profit-seeking purpose with health for all?
Okay, got it. Thank you, Fatima. Great question. So maybe I will go to our two ladies here. Go ahead.
Okay. Can you hear me? Okay. So thank you so much for your question. And I think this is where really the power of partnership comes through, to ensure that, working with partners who are willing to provide financing to enable organizations to be able to continue with the research and development of new treatments, but at the same time ensuring that there is access to medicine. And from an organon perspective, I can share that we do work with multiple organizations who support the financing, supporting governments as well, but also supporting us to expand our production of some of the products that we have to ensure that we can make them available at a reasonable or an affordable price for many people on the African continent. And also when we look at our pricing strategies, we take that into consideration and look at the various people that we are actually servicing and ensuring that they have access to the life-saving medication that we do make. But I think key here is around health financing and also the partnerships, but also with government and also other private sector entities.
Great. Do you want to respond?
Can you hear me? Okay. So I want to chip into that from a different angle, which is that, private sector will, yes, whether you like it or not, first of all, healthcare is a business. How much profit you make or none thereof, is very subjective. So we have to keep that in mind. But again, we are going to the fundamental basis of healthcare for all, universal health coverage. And this is what we are grappling with in a lot of African countries, especially, let's say, for example, Nigeria, where 70% is out-of-pocket payment, and at the same time, you have a significant population living on less than $2 a day. So already, they're at a disadvantage. And because the public facilities are also a no-go area, the advantage shifts to private sector. So, these are market forces. We have to look at it in terms of demand and supply. So how do we mitigate that is really where we come to public-private partnership and the role of government. The role of, ensuring that there's a premium package with a minimum benefit package. How much is going to be paid, at least that can be set, which is what is happening in a lot of states within Nigeria now. There's a national health insurance scheme, there's a minimum basic package, and it is already priced. There's a fee schedule for providers, and so on and so forth. So basically, you can govern the way healthcare is provided. Of course, there are going to be outliers in the private sector, and people can choose to go there if they want to, the top-ups, the bigger hospitals, and, they can charge what they want because they've invested in the infrastructure. But the onus remains with government to ensure that, there's a level playing field. And just not to take up so much time, I want to give one small example of a public-private partnership that is happening in Delta State in Nigeria, which is where we had brought in through the Healthcare Federation, private sector, to take over some non-functional primary healthcare centers, about 15 of them. And it's unbelievable the kinds of results that we're seeing following an impact evaluation. The pricing is enough to enable the communities access care. Because of the health insurance, those who cannot afford to pay are covered by an equity fund. Those who can afford to pay their premium. But ultimately, the quality of care, because it's being run by private sector, it's the same as you will get in their normal hospitals, the normal private sector hospitals. And I can tell you that two impacts that we've seen: zero maternal mortality in those 15 clinics in the period of 3 years compared to the average. Nigeria has the highest number in terms of under 5 mortality and maternal mortality. But we've seen a significant change because private sector is involved. So private sector is not really all about, high costs, but depending on the environment, because now they have a cohort of enrollees, the methodology, capitation, fee for service in a community where there's no hospital, there's only one private sector in, operating the public facility in a PPP. Of course, the prices are low. Of course, they're able to cover their costs and make profits. So it's all about the environment, it's all about the partnerships, it's all about how it's structured, and so on and so forth. So private sector is not really always about high costs and charges, but there are systems around which, we can mitigate this, and that is what we really need to focus on going forward.
Yeah, thank you. And there are lots of examples, honestly, around the world on what not to do, right? Where, in the United States, it's one of the highest costs for healthcare. So it would be interesting as the continent grapples with this to also look at some of the examples of what not to do and avoid those, because we can. There are good examples. Go ahead.
And I think there is a need for consideration when it comes to price and regulation in market as well. That, so there might be in some countries a need for government to step in terms of regulating that part of the business as well. Mm-hmm.
Thank you. Do we have any other question, or are we good? Oh, please go ahead. Mic runners, if you don't mind. Okay, so we've got one there. I can go to you, and then 2 more here, and then we'll end. Thank you. Go ahead, please.
Thank you so much. My name is Moses Mulumba. I come from Kampala, Uganda. I think that the role of private sector is extremely important. But we miss the governance question, especially if we are to talk about private sector on the African setting. Africa as a continent has built its governance and the engagement of health systems from a perspective of public health systems that are provided as public. Now, we have private sector overemphasized as important, and the regulatory frameworks are not changing. In fact, what is happening is that governments are regularizing private sector rather than regulating it. And we need to make a distinction between regulation and regularizing. Every time people talk about private-public partnerships, it's never about regulation. It's about regularizing the private sector. And because we have that challenge, I think we need to address that governance question. At the same time, think about governments investing more in delivery of services. Thank you so much.
Thank you for the comment. Thank you very much. So I'll take, I'm sorry, one more question. I was told we're running out of time. I had somebody on this side.
Okay. All right. Thank you so much for your presentation. I'm Bibi from Cameroon, and I have a question with regards to community participation when it comes to healthcare. Yes, it's true that the government has a very big role to play with buy-in, like in terms of sustainability. But now, in a case where we have a running project where we want a community leaders to take part in the project, for example, lead discussions about public health, about health, maybe with reference to a specific disease, let's say malaria. Now, the project ends and we really want that the project should continue within that community. So what can be done in the case where they need incentives in order to go on without a project? Now, the project has come to an end, and you really do not have incentive to continue with a project. At the same time, we need them to continue having those community discussions so that maybe every month they have like action plans, like what can be done to curb malaria. Maybe we need to clear the grass and so on. So what can we do to motivate these community leaders to continue with this project even after the project ends, when they really do not have, when we really do not have incentives to encourage them?
Got it. Okay, thank you. Moses, do you want to take that? Thank you.
I will just respond to the community engagement question, because we do work a little bit upstream in the continuum of care building for public health. I think currently integration of community engagement experts very, very early on is absolutely important. And I would assume even when we get to implementation science, it will be the same thing. Pulling in social scientists, pulling in anthropologists into your work would be absolutely important. Otherwise, if we wait until it's too late, then it really becomes a challenge getting buy-in. I mean, we all know Femidom, the female condom actually failed because some of these issues. Yeah.
All right, thank you. I wish we had more time. Thank you for the question, and thank you for our panelists. I hope we heard some stories that we can take with us. And thank you for tolerating my laryngitis. So I think we will wrap up our session, and Monique will help close the session. Thank you so much.
Hello? How do you put this on? Hello? It's on. Can you hear me? Yes. They were great, weren't they? Can we just give a big round of applause for them? I think this whole of society discussion, the power of engaging civil society, community actors, and the private sector, and the youth, this was really a very good conversation. So I had so many things, I don't know where to start. And there were everything that they said were point, so I will try. What I had was partnerships. Partnerships being described in many different words. There was action-oriented partnerships, there was diversity in partnerships, equal partnerships, and so on. So the most important topic was that of partnerships. So it is partnerships, partnerships, partnerships. As Africans, if we have to go somewhere, if we have to, secure our future, we really have to embrace the whole of society. We have to embrace everyone.
and we have to work via partnerships. So that was one. So we need to work together, and we can do more if we work together. The other thing I had was governments. Yesterday, the acting director of Africa CDC, Dr. Ahmed Ogwel, a good friend of mine, he talked about Africa CDC and African Union. The presidents of Africa were listening to them. And in 2 months, they had had 12 meetings. Can you imagine that? And they really did so much for their citizens. They listened to the advice of Africa CDC, and I think that's why we are here today. Otherwise, we are dropping in the streets, as my sister said. And so governments, really, I think we have to encourage them to really take leadership. And as you heard Omar said, leadership matters. And I think I'll add, African leadership matters. We need to be leaders in everything. And, we need to pull the youth, as we move along. So leadership matters. Also, I had that the academia, in academia, they are youth. And so we have to bring them to the leadership of today, because they are also leadership of tomorrow. So if we exclude the youth, we will not have a future in the continent, for our continent and for our community. So that academia was also one of the things that was said. There was also about private sector, and my sister spoke so passionately about private sector, and Omar as well. Private sector is part of the solution. We need to embrace private sector. Okay, and then we remember also what Omar said. Tomorrow belongs to those who prepare today. Okay, we have learned so much from COVID. COVID opened all our eyes. Even people who didn't want to open their eyes, they really opened their eyes. And it should never, ever happen again. So we have to learn that lesson. We have to keep our eyes open. And we have to plan, because planning for tomorrow belongs to those who prepare for today, so for only those who plan. I also had, I'm just giving you phrases and catches, what I had, and we can fill in the gaps. There was also what Moses was saying, that, they didn't have money. When COVID came, they realized, oh my God, the money was freezing out. All of us actually felt that freeze. There was no money anywhere. Yeah? COVID took the money. Everybody went to COVID. So can we then plan such that we can plan for the next pandemic, so that we don't have empty coffers? We have money to do research and money to do everything that we want to do. So COVID has really taught us, more so the African continent, and let us really wake up and let us embrace each other. Okay, so the private sector have managed to pull a seat to the table. You heard about the seat, and I was very proud that they have pulled a seat. So wherever you are, an African leader, working with our partners, pull a seat, because if you're not at the table, you're not anywhere. So we have to empower each other to be at this seat. Of course, partnership, we must not miss the voice of the women. And I'm proud to be standing here as an African woman and saying that the African women, they can really multitask. They can be cooking, carrying a baby, I don't know, doing what, everything. So partnerships, voices of women must be heard. And women are a critical part of our society. So women, let us arise. We have been empowered. Don't be left behind, because we have an impact in society, and we have been embraced by society. So in conclusion, so those are the phrases I had. So this whole session was about Agenda 2063, the Africa that we want for generations to come, is that of shared prosperity, well-being, unity, integration, a continent free of free citizens, and expanded horizons, and free from fear, disease, and want. In this regard, we need everyone to play their role: governments, communities, scientists, researchers, civil society, faith-based organizations, the youth, the private sector, everyone. I believe the future is bright if we continue to partner and work together. Be your brother, your sister's keeper. And as the African proverb says, because I also want to end with it, if you want to go fast, go alone. But if you want to go further, go together. And so let's embrace each other. So thank you very much. It was a pleasure. I hope I've not kept you from lunch. Thank you very much. And once again, it will not be good without you, so give yourselves a big applause for coming. Thank you. Thank you very much, Chair, Kedest, and everyone who was involved in this. Thank you, and thank you for Government of Rwanda. It's a pleasure to be here. Thank you.
Thank you for our great panelists and moderator. We're now going to break for lunch, and we'll be back in this room at 1:30 with our parallel session 8A. Enjoy lunch and see you back at 1:30. Again, please leave your headsets on the chairs. Please leave your interpretation headsets on the chairs.
Thank you so much.